I leave it you.
Hello, good afternoon, everyone. It's now precisely 4 o'clock. We're gonna wait for 1 or 2 more minutes until people can join the online seminar, and then we will get started. Hi, Hussein, great seeing you.
Hi, Matthias, how are you?
How's it going? Excellent, thanks for joining.
Absolutely, good to see you too, and thanks for the invite.
Oh, thanks for accepting the invitation, fabulous.
Great. Sad that it's not in Zurich, but it will happen.
There will be a 4th or a 5th BrainMed meeting, and that will hopefully, I dear hope so, be a live and face-to-face meeting again.
I sure hope so.
Maybe it's going to be a 6th, so let's see how the pandemic goes.
How's Switzerland doing on vaccinations?
Well, doing okay-ish, could be better.
I live in Texas, so I'm not gonna comment.
Okay, so people are still joining. We wait for 1 more minute and then we get started. Okay, it's 2 minutes past 4. Let's get started. Good evening, good morning, good afternoon, in whichever time zone you're living. I would like to warmly welcome you to our 3rd Zurich Brain Metastasis Symposium. This is the 2nd day, so I warmly welcome you, and I'm very happy that so many of you have joined for our 2nd day. I would like to thank the Comprehensive Cancer Center for organizing this symposium, and in particular, Silke Uflacker. Maybe you can switch on your video, Silke. We haven't seen you yesterday, and I would like to thank you. And so people recognize you. Silke, it was perfectly organized. I say that at the beginning already. Thank you very much. Also, I would like to take the opportunity to thank our industry partners kindly supporting this symposium. Without their support, this wouldn't have been possible as well. I will not make a longer introduction because we have a very interesting program in front of us, hopefully with lots of discussion. I would like to invite all you participants to join our discussion, use the chat functionality to interact, to ask questions to us as speakers, and also into the audience. We try to bring and integrate them into the symposium. With that, I would like to start and kind of explain the background of today's talk. It will be dedicated to the optimal combination of systemic and local treatment to optimal interdisciplinary collaboration to achieve best outcome for our patients with brain metastasis. Let me share my presentation. Okay, can you see my presentation?
Yes.
Okay, excellent, thank you. So the background between sequencing of radiosurgery or radiation and systemic therapy. I would like to give a background why we think this is an important topic. First of all, we have to acknowledge from the field of radiation oncology and from systemic therapy that we are seeing a tremendous progress in the fields of local and systemic therapy. Just talking about radiation oncology, SRS radiosurgery, which has only been made available and dedicated in specialized centers. This is today possible and widely available as a standard of care. And this is not only restricted to a single metastasis, but can be applied in a very efficient and patient-convenient fashion to multiple brain metastases. Tremendous progress from a local perspective. But of course, we also acknowledge that there has been tremendous progress for systemic therapy. Targeted therapies have become standard of care for many tumor entities, and the same is, of course, true for immune checkpoint inhibition. And what is required is a deep understanding between disciplines, between people who have a dedicated focus on either or technology and development. And maybe there was some misunderstanding, that there was a lack of a common language between these disciplines when discussing how to optimally combine and choose between or combine different treatment modalities. And I would like to give the perspective of both sides, from radiation oncology and systemic therapy, and by doing so lay the ground for the later on presentations. So what is the perspective of radiation oncology? Well, this is a summary. Radiosurgery, one could say, is a standard of care. It improves overall survival for limited brain metastasis. It does so by achieving deep and durable local response. Radiosurgery, it is associated with low rates of toxicity, and as a consequence, SRS is an evidence-based standard of care, and its omission or a delay would require appropriate clinical trials. That's just a quite a blunt statement, but what is the evidence behind it? First of all, a comparison. Why are brain metastases different? Why do we need a dedicated symposium to talk about brain metastasis and not about liver metastasis or lung metastasis? Obviously, they share characteristics. It's both metastatic cancer, it's a frequent route of spread into the liver and brain. And yes, both are associated, or at least have been associated, with a poor prognosis. A major difference comes from the patient perspective. The symptom burden for many metastasis locations and also liver, it's most frequently low. This is different for our patients having brain metastasis. Something all of you know, that patients with brain metastasis, they have, in the majority, still today, the majority do develop symptomatic disease, not only just one symptom, but a complex picture of different symptoms. And these brain metastases, they do have a tremendous impact on quality of life of our patients. So we do need, in particular, effective therapy, local and systemic, for this situation, for patients having brain metastasis, to not only improve survival, but also to keep them locally controlled, to limit their influence on quality of life of our patients. And what is of particular concern is obviously neurocognition. Neurocognition is important as a consequence of brain metastases themselves, but also of the treatment itself. We do know that brain metastases just at baseline, at presentation, if they're symptomatic, they do have an influence on the neurocognitive function. 90% is impaired just due to the existence of metastasis within the brain. There's not a lot of space where brain can kind of evade. So this is, from a mechanical perspective, quite obvious. And this is also obvious that volume and the number of brain metastases, this is correlated with the impairment of neurocognitive function. On the other side, the response to local therapy and also systemic therapy, it is also associated with neurocognitive function. Progressive disease, it will ultimately result in a deterioration, and a higher degree of volumetric response, so a deeper response of brain metastasis, this will result in a long-term preservation of neurocognitive function. So what we want to achieve in brain metastasis is not just a stabilization. What we want to achieve is deep and durable response, which might be different compared to other palliative settings with metastasis in other organ sites. Can this be achieved safely? And I just focus on radiosurgery, a very focused type of radiation, many of you know, and something we are concerned is, and the most concern is radionecrosis. Because radiation is so focused, neurocognitive function is not so much the issue anymore. It's the damage to the brain in the immediate kind of next to the brain metastasis, the area which is exposed to higher dose. After single fraction radiosurgery, there is a slightly higher risk of radionecrosis, up to 18% in a systematic review. But as soon, and this is today possible by technology, as we fractionate radiosurgery, not delivering all radiation in one fraction, but divided up in 3 or 5, the toxicity profile becomes very favorable. 7.1% of, in this series, mostly larger brain metastasis. So in the more modern series, which are applying something we call risk-adapted fractionation using radiosurgery, single fraction for the small ones, fractionated radiation for the larger brain metastasis, the overarching risk of radionecrosis is usually below 10%. And keep in mind, this is all grade radionecrosis. The majority of them do remain, fortunately, asymptomatic. So this is about safety. How about efficacy? I will show you experiences from 2 large centers in series on local metastasis control, which I pointed out is an important endpoint, and also the depth of response. How much volumetric regression do we achieve? And this is the data from our own center in Zurich, 350 patients treated for more than 1,000 brain metastases. And you can see here the local metastasis control for the smaller and the larger metastasis. And you can see that for both cohorts, the 18 months local metastasis control was 90% or higher. So long-term control is indeed achieved. And it is not only control. We see a dramatic, rapid, and deep response of brain metastasis. Already at about 1 month, we see a tumor regression of 25%. And this is the median metastasis volume compared to baseline. It will end up at only about 10% to 25% after 12 months. So in the vast majority of our patients, more than 90%, we not only achieve a durable control, but this is combined with very deep response of 75% or more as a median. And this is the rationale that local treatment also does translate into an overall survival benefit. This is an old trial. We have to acknowledge a disease agnostic trial, but still 60% of the patients had lung cancer, the RTOG 9508 trial, where patients with limited brain metastasis were randomized to whole brain irradiation, which is a palliative regimen, and SRS in the experimental arm. And in particular, for patients having a good prognosis, there was an overall survival advantage of using more intensified radiosurgery, as I've shown you, for deep and durable brain metastasis control. Recently, it has also been shown that applying the same principle, radiosurgery, to a larger number of brain metastases, this also achieves good overall survival and is not associated with increased complications. There are some technical details which have to be considered in terms of total volume of metastasis, which can be treated safely. But today's technology is able to deliver this very focused, very precise treatment also to a larger number of brain metastases. And based on this, Emilie Le Rhun has shown it yesterday. This is the recent EANO and ESMO practice guideline for brain metastasis. The use of radiosurgery is a standard of care. Level 1A evidence, radiosurgery is recommended for patients with a limited number of brain metastases, and radiosurgery may be considered for patients having a higher number of brain metastases and a somehow limited volume, and here the evidence is lower. This was the radiation oncology perspective, but obviously there's another perspective, and we want to give kind of today this really interdisciplinary room to interdisciplinary discussion. The medical oncologist would say, well, brain metastasis, it's an indication of a systemic disease, so we need systemic therapy, no discussion, whatever. We have radiosurgery, it is kind of been proven in clinical trials, but they have been conducted, the RTHG trial, in the area before effective CNS-directed therapy. And there are concerns when new modern systemic therapy approaches are combined with radiosurgery. So the hypothesis could be that effective systemic therapy is the standard of care and local radiosurgery can be applied on a response-adapted way. And of course, we are in a very lucky and happy situation that we do see tremendous progress in systemic therapy, not only in the extra CNS setting, but also for CNS for brain metastasis. And this is just as a proof of principle, as just one indication, non-small cell lung cancer, ALK translocated, efficacy of crizotinib, but even better for alectinib and brigatinib, achieving very deep, very favorable response rates. And the same is also seen when using immune checkpoint inhibition. Also here we can see in selected groups, this will be discussed later on, durable and deep response. And here the authors concluded that nivolumab combined with ipilimumab should be considered as a first-line therapy for patients with asymptomatic untreated brain metastasis. This conclusion was kind of the basis for a heated discussion. And this is just illustrated in this picture. And this is the scientific kind of the same picture, not showing a drawing, but a letter which was sent to the journal after this conclusion was being published. This was published by some very engaged radiation oncologists, and they had some concerns about this quite strong conclusion. They complained that there was no formal hypothesis, no neurocognitive testing being applied, that the standard of care being radiation as a local treatment, as I've shown you before, was not considered in any of the arms. So effectively, a non-inferiority design should have been used. And overall, the response rate, it was just 46%, which cannot be practice changing, which might be true or might be wrong. But this is the context of a local treatment discipline, the context of radiosurgery, where I've shown you a median response and regression of more than 75% and durable local control of 90%. But we also have to acknowledge that we need a better interdisciplinary perspective, and we need to have a better picture what is actually being done in a longer perspective trajectory of our patients. This is something which is kind of a bit unilateral, I would say. This is an overall survival curve of ALK translocated non-small cell lung cancer, showing overall survival, which is very promising. This is true. This is the result of systemic therapy. But on the other side, it was also the case, and this was reported in this series, how many local interventions have been performed. And you can see that the majority of patients, more than 50%, had 2 or more local interventions. So this very favorable overall prognosis, 50 months median survival for patients with brain metastasis, it was the effect, the result of a combination of a systemic and local therapy. So the combination was here what I want to emphasize. We also need to acknowledge that we may not know as much as we would love to. Even in terms of strategies, what are strategies we can or should apply to our patients? We could say, well, upfront local and systemic therapy. That could be one strategy which is being proposed and being tested in prospective randomized trials. Another study could be, well, if we don't have an extra CNS progression, why do we need systemic therapy in this setting of effective local treatment? So just put upfront local therapy and then delay the need for systemic therapy. Of course, you can have an opposite strategy, upfront systemic therapy, and apply local treatment only at a later point of time. This could be for residual disease, something which is being left over by systemic therapy, or even longer, just wait long enough until the patient progresses and then apply local treatment. These are all strategies which have not been evaluated in prospective trials yet, which have not been compared, where we do have strong opinions, but truly a lack of evidence. And this is just one picture. There's many other aspects. What are the follow-up and imaging intervals? What is the compliance of our patients if we ask them to have repetitive MRIs every 2 months? Do we have the resources for this imaging? What is the trigger for systemic and local intervention? And of course, in brain metastasis, we do have much more parameters which need to be considered: number, volume, location of brain metastasis, the symptom status of our patients, use of steroids, performance status, extracranial disease, systemic therapy options, and locals. So there's many parameters which might become difficult to answer them all in randomized controlled trials. So what we will need in the end is close and interdisciplinary discussion. We need tumor boards where the best approach is being decided for each and every individual patient. But this is not what we aim for today. Today, we are aiming for a different kind of picture. We want to engage an interdisciplinary exchange. So we have organized 4 talks in the following of 4 kind of clusters. 3 clusters addressing the issue of sequencing of radiosurgery and systemic therapy for breast cancer, lung cancer, and melanoma. And we have asked 1 medical oncologist and 1 radiation oncologist to bring up their arguments and points of view how to best approach these specific situations, because we have left this disease agnostic way. We need to acknowledge that we need more precise, more tailored medicine. This is one perspective, interdisciplinary exchange, but we also want to kind of emphasize the need for prospective clinical trials, which is challenging, and this will be addressed by my co-chair, Michael Weller. With that, this was only meant as an opening. So if there would be urgent questions, I would be happy to answer them. Otherwise, I would propose that we continue with the first talks and then have a bit more time for discussion when we reach the respective tumor entities. But are there specific questions at this point of time? I see 1 question in the chat. Let me just read it. Some centers seem to no longer consider the number of lesions as a limiting factor for SRS. This is an excellent question. This is more from a radiation oncology perspective. What can be performed safely? And safety means how much radiation can you deliver in a safe way without increasing the risk of toxicity, of radiation-induced toxicity. Traditionally, we use a number cutoff, which does not make a lot of sense from a radiobiology perspective. It is the volume which causes the toxicity. So we do have a volumetric component, but we also now acknowledge in a better way that volume plays an important role. For example, the Yamamoto trial, which I've shown you, where SRS has been applied to more than 4 brain metastases. This used a volumetric cutoff point of 15 cubic centimeters to kind of have an indication for single fraction radiosurgery. Okay, I do not see any further questions in the chat. So that means we can start slightly early and have more time for the interdisciplinary discussion afterwards. With that, I would like now to come to the first kind of debate or topic or exchange addressing breast cancer, where we have also seen tremendous progress in systemic therapy, specifically for patients having been HER2 positive. And we have the pleasure having 2 very distinguished speakers about sequencing, radiosurgery, and systemic therapy for breast cancer. Emilie Le Rhun, I do not need to kind of introduce, who has been kindly enough of speaking twice in our symposium, so thanks for jumping in very quickly. And Giuseppe Minniti, also very well known to our field, being professor at Pittsburgh University, being leader in the field from Italy. So thanks for the 2 of you for joining. And the floor is yours, Emilie, to set the stage for the perspective of systemic therapy.
Thank you very much, Matthias. I hope you can see my screen. Okay, thank you. So my role today is to defend a bit the role of systemic therapy for the management of brain metastasis of breast cancer. So systemic first, this is my topic. Oh, sorry, I have to move the slide. This is my disclosure slide. So this is the outline. So first I will address the drug penetration into brain metastasis, the efficacy of drug at the CNS level, toxicity of radiotherapy, and extra CNS disease and cause of death in breast cancer patients with CNS metastasis. So we start with the drug penetration into brain metastasis. So this is a paper, so this is interesting because yes, we have this blood-brain barrier, and here they have looked at protein expression in the microvessels of brain metastasis. And here, so you can see, for example, these are two efflux transporter. And so here so you have a normal brain or control. Here that's a glioblastoma, and here you have lung cancer and breast cancer. So what we see is that these efflux transporter are reduced, in fact, in the microvessels of brain metastasis. So yeah, this is something that, is important, I think, to know more about this aspect. And here, this is a bit older paper that was published here almost 10 years ago now. And so I think that's also an interesting paper. That's mouse model. So here you see with the green color, the metastatic cells in the brain. If with the Texas red dextran, you can see where's the integrity of the blood-brain barrier. And when it's red, it's disrupted. And then you can see you have the lapatinib. It was a drug example. So the drug concentration into the brain metastasis. And you can see that it's very heterogeneous, but it's there. This is another paper that I found interesting as well. This is a phase 0 study. So it's patients who are treated before surgery, and then they look at the concentration into the brain metastasis of the patients. So for capecitabine and lapatinib again. So here you have the ratio of the concentration into the brain metastasis versus serum for capecitabine here and the metabolites of capecitabine. And here you have also the brain metastasis on a serum ratio. And also we can see that in the brain metastasis, the concentration of the drug vary a bit between the patients. It's not always the same, so that's a bit heterogeneous. And this is another paper that I also wanted to show you. That's a trial, we discuss about that later, but here, this is also phase 0 of from this trial. So it was abemaciclib, and it was also given prior to surgery for brain metastasis. And you have the concentration in red in the brain, in gray here in the plasma, and in the CSF here. And I think what is very interesting that at least we see we have a good penetration of the drug into the brain metastasis. So it's not a problem of penetration for this agent, but we also see that the penetration, the concentration in the CSF doesn't really reflect the concentration into the brain metastasis. So I think that's very important, and we cannot say, okay, we look at the CSF blood concentrations at the same as the brain blood concentration. That's not a surrogate marker. So that's important. Let's now discuss about efficacy of drug at the CNS level. So this is studies that start to be a bit old now, so it's almost also 10 years ago that we have done in France with Thomas Bachelot, the landscape study. And I think it was, for me, it was a time when we started to think that yes, systemic treatment may help to delay whole brain radiotherapy, and this was shown by this trial. And I think since then a lot has happened. And we have different studies. So this study of neratinib plus capecitabine, so in the subgroup of patients from the NALA trials, that shows also interesting progression-free survival in patients with brain metastasis. And of course, we have this HER2 claims trials that was recently published on patients with brain metastasis. And clearly, you can see here, so the addition of tucatinib, trastuzumab, and capecitabine versus the placebo trastuzumab and capecitabine, clearly that's PFS and the OS. It's very convincing data. So here it works. And then they also have looked at patients, subgroup of patients with stable, what they call stable brain metastasis diagnosis and active brain metastasis diagnosis, and it's efficient. And also they have done a sub-study to look at the preservation of the quality of life in this patient, because they received one more agent. But what we can see is that the quality of life is preserved in the treatment arm versus the placebo arm. So at least when we maintain this neurological status without progression, and the quality of life level is also maintained. This is the other study on abemaciclib that I've already shown. So here, unfortunately, the primary endpoint was not met, so it was not a problem of the drug penetration to the brain metastasis, but that was heavily pre-treated patients. I think what also is interesting here, that when you look at the intracranial response and extracranial response, it's a bit the same. So that's also an important information. Let's talk about toxicity of radiotherapy. So this is a German study. So here they look at the quality of life in patients. So they were treated by whole brain radiotherapy or SRS. So here you have, if it's high, it's good. So here it's not good. So higher score is better. So you see you have a decrease here, significant decrease. This is after whole brain, and this is even after SRS. So they show a bit of reduction in physical function. And if you look here at the different subscore, and here, so in B, so a higher score is worse. So even after whole brain radiotherapy, after 3 months, you have more fatigue, but also after SRS. So it's not that SRS has no secondary effect. You see something also on the quality of life of the patient. And so this is another study done by the group of Martin Taporn on patients that were treated with stereotactic radiotherapy for the brain. Here they look at the cognitive function. They didn't see any significant difference for this patient. Again, on the quality of life, a bit of significant difference for these two items. Then when we look at this is also the group of Martin Taporn. They also look at the neurocognitive changes after SRT for oligo brain metastasis. So in patients treated with SRS, and here you see that for some domains you have deterioration, but for others you have also improvement. And then last, extra CNS disease and cause of death in these patients. So this is a paper that look at the cause of death, in fact, of patients with breast cancer patients with brain metastasis. And they have almost the same rate of neurological death and non-neurological death. I think what is interesting that for breast cancer, they are here in green. There are no real differences between the two groups, which is not the case when you look at the melanoma. You have much more patients who have brain metastasis who die of the CNS disease. another paper, this time on breast cancer brain metastasis treated by SRS. And here we see the systemic death and the neurological death. So clearly, it's not the same for all the subtypes of breast cancer. And maybe, yes, the triple negative patients have more neurological progression, and probably then need to be retreated more often. This is more the challenge for this patient. So in conclusion, I think we can follow the new ESMO guidelines, and it's allowed to do surgery followed by systemic pharmacotherapy or pharmacotherapy alone for patients with favorable prognostic factor, and systemic pharmacotherapy alone for patients with unfavorable prognostic factor. This is my conclusion. Thank you.
Thank you very much, Emilie. Other questions? Please use the chat functionality. Some of you have already started. Please just use the chat to ask your questions and also comment the presentations. That will make our symposium much more lively, much more interactive. We would value that a lot. If there's no immediate question, I would hand over to Giuseppe and then have a discussion afterwards. Okay, Giuseppe, you already mentioned it's going to be hard for you. So before we start with the talk, I can see that Giuseppe prepared a question. Do you want to moderate? Giuseppe, you're muted. We can't hear you, Giuseppe. You need to unmute yourself. No, we can't hear you. No, you're still muted.
Okay, sorry.
Now, perfect. Okay.
Sorry, I don't see the question. So probably okay. So I see the question. Okay, I can. This is my first the question before my talk. What would be your treatment approach in a patient metastatic HER2 positive breast cancer presenting with a large single brain metastasis of more than 3 centimeters in size, causing problems with balance and walking? So this guy has a performance status, this lady has performance status 1. Symptoms partially recovered under steroids. So we have 5 options. Upfront neurosurgical resection followed by postoperative radiosurgery to the surgical bed together with systemic treatment. Upfront neurosurgical resection followed by whole brain radiation therapy. Upfront neurosurgical resection followed by radiosurgery. Upfront radiosurgery followed by systemic treatment and systemic treatment. So we have already seen also the talk yesterday from Arjun Kumar talking about preoperative radiosurgery, but this is the question, these are the answer for the audience. Okay, we have the answer. 75% of patients say that upfront neurological resection, followed by postoperative radiosurgery and systemic treatments was the most used treatment, together with almost 20% upfront neurosurgical resection followed by radiosurgery. This is an interesting answers. So probably we will discuss the answer to the question at the end of my talk. So also we can see if someone changes idea regarding this approach. Okay, can you see my talk? Okay, thanks. So after Emilie Le Rhun that talked about the systemic treatment in brain metastasis for breast cancer, I will try to defend the role of radiosurgery together with systemic therapy for these patients. So these are my disclosure. And this is the outline. So Emilie has already talked in an extensive way about the systemic treatment for breast cancer brain metastasis. So I will focus more on radiation for breast cancer brain mets, and which is the efficacy and safety of combining radiosurgery with systemic treatments. So also yesterday we had a look at the new EANO-ESMO clinical practice guideline for the treatment of patients with brain tumors. And when we look at the systemic treatments and breast cancer, you see that regarding the recommendation about pharmacotherapy, we see that systemic treatment of asymptomatic and oligosymptomatic brain mets should be considered for delaying the whole brain radiation therapy in HER2 positive breast cancer patients with a very good performance status. On the other hand, for HER2 negative breast cancer patients, we should consider classical chemotherapy together with an emerging role of immunotherapy. So Emilie has already given a view of all these trials that at the end of the day have demonstrated that there is some intracranial activity of target therapy and chemotherapy given as single agent, or even better if combined. So we already have seen the landscape study on the combination of lapatinib and capecitabine, the NALA study, the MEDIA study. And also we have a study like Cleopatra study and Cerbel study addressing the role of such target agents and capecitabine to prevent the development of brain metastasis, while for brain metastasis with HER2 negative luminal or triple negative breast cancer, there is, as I say, an emerging role for immunotherapy, specifically atezolizumab and pembrolizumab. So if we look at this interesting meta-analysis, systemic review on the role of HER2 target therapy for HER2 positive breast cancer, we see that we have an advantage in survival for people having target therapy, mainly lapatinib, plus with or without other agents like trastuzumab, pertuzumab. But even if there is an advantage of survival, we can say that when we look at the intracranial overall response, so there is a 20% with lapatinib, which can rise to 50% for patients having combined capecitabine and lapatinib or lapatinib and trastuzumab, but still we are far away from the local control that is usually observed after radiosurgery. So this is something we have to think when we decide to approach these patients, especially for patients with large and symptomatic lesions. So the question if there is a role for upfront systemic treatment for HER2 positive breast cancer has been addressed by this recent updated guideline from ASCO. And they say that if we have an asymptomatic, low volume cumulative metastasis which had not received radiation therapy, we can discuss about some option. Firstly, lapatinib plus capecitabine based on even a small prospective trial, the landscape trial. So we can say that in selected patients with very small lesions and very good performance status, we can consider this approach. And this is also an update from the ASCO guidelines. And the question, the addressed question was, there is an optimal sequence of chemotherapy or target therapy for patients with triple negative metastatic breast cancer? And the answer is for patients with express PD-L1 receptor, we can consider checkpoint inhibitors together with chemotherapy, like pembrolizumab plus chemotherapy or atezolizumab plus chemotherapy. Or of course, we don't consider immunotherapy for patients with breast cancer without expression of PD-L1. And in this patient, we should be offered chemotherapy, but certainly after radiotherapy. And okay, this is for patients who failed 1 or 2 lines that can be treated with this sacituzumab, which block a receptor, troponin receptor, and carries a drug, which is a metabolite of irinotecan. So, and now we start with the role of radiation for breast cancer. Matthias has introduced the technical advances that we have seen in the last decades for radiotherapy, and we know that there has been a shift from whole brain radiation therapy to radiosurgery. This is based on different randomized study which showed that there is no difference in survival when we use radiosurgery alone versus radiosurgeries plus whole brain radiation therapy or whole brain radiation therapy. And so we can see there is a similar survival, but the most important endpoint of this study, at least in Brown trial, was that together with similar survival, we have an advantage by using radiosurgeries versus radiosurgery plus whole brain radiation therapy in terms of a neurocognitive outcome. So when we do radiosurgery, in this case for a limited number of brain metastases, we have an advantages in terms of neurocognitive outcome. And this was seen also by the same author in this trial, addressing the radiosurgery, the postoperative radiosurgery to the resection cavity. And again, similar survival, but better neurocognitive outcome for patients treated by radiosurgery versus whole brain radiation therapy. So if we look at the summary of recommendation, also from these ASCO guidelines, we say that for patients with 1 brain mets or with a limited number of brain mets, treatment options include surgery, include radiosurgery with or without whole brain radiotherapy, depending on the size, the site and the symptoms of the patients. What is I think is very important, it's very important, and that together with the radiosurgery that traditionally, as also Matthias said before, was delivered as a single fraction radiation, now we have an emerging role for fractionated radiosurgery, especially for larger mets. And this is because we know, this is our experience, this experience can be shared by several groups. For large lesions, we can have a better local control using 3 or 5 fractions, but most important, we have a lower risk of radiation necrosis compared with single fraction. What about patients with several, more than 5 brain mets? Here, accordingly to the ASCO clinical practice guidelines update was in 2018. So for people with more than 5, for patients with more than 5 lesions, clinicians may recommend whole brain radiation therapy. So it's incredible, like in 3 years, we have changed this view. And so what should, at least in my perception, what we can do with patients with more than 5 brain mets? This slide was already shown. This study is an observational prospective study of more than 1,000 people, showing that then we treat with radiosurgery. This was single fraction radiosurgery. Patients with 2 to 4 lesions or from 5 to 10 lesions, we have similar survival. And also, Emilie showed a lot of study looking at the very good neurocognitive outcome with systemic treatments, but I want to reassure that also with radiosurgery, we can achieve an excellent neurocognitive outcome. this is what now the advances in radiosurgery techniques allow us to do. This is a technique, it's called single isocenter multiple targets techniques, which means that we target a number of lesions up to 20 in this paper in just one single session of half an hour. And we look at, in this prospective observational study, at the neurocognitive outcome. And as you see for these patients, and you can see also as a figure, so in terms of memory performance, we have a very slight decline, which is equivalent to that seen in randomized study with patients with a limited number of brain mets. So we can say that when we treat multiple mets, we can have an excellent neurocognitive outcome. So that's the reason, because we have changed this paradigm in the EANO-ESMO guidelines recently published, saying that radiosurgery should be considered for patients with up to 10 brain mets, maybe more. What is important is this cumulative tumor volume. 50 mils is not is a huge volume. It means 30 brain mets of 1 centimeter in size. It's a huge number. But I still believe that if we use fractionated radiosurgery, probably we can go over volume higher than 50 mils. So what about the combination of radiosurgery with systemic treatments? So looking again at the EANO-ESMO clinical practice, I have to say that so there is a lack of trials using this combined modality treatment. And specifically in breast cancer, no study has defined the best timing of systemic treatments and even the best combination in terms of fractionation, in terms of dose, in terms of interval between radiosurgery and systemic treatments. So it's true that we don't have prospective study, but we have some large retrospective study that can give us at least a base for a rationale for future prospective study. This is a study looking at the combination of radiosurgery with concurrent lapatinib or no concurrent lapatinib, and as you see, there was a better response in patients treated with lapatinib and radiosurgeries in terms of local control compared in terms of response rate compared to radiosurgery alone. And when you see the table, we have a complete response, a partial response in almost 90% of patients compared with 70% of patients with no concurrent lapatinib. This means that this combination, even if, as you see in this figure, which look at the cumulative incidence of failure at 12 months, even if you see that with radiosurgery alone, there is a failure of 13–14%, which was higher than when we used lapatinib and radiosurgery, but still it demonstrates that also radiosurgery alone can achieve an excellent local control, but it's important to use, in my view, both drugs also for the global brain progression-free survival, which is better with combination. We have other very small retrospective study looking at the same at the efficacy of trastuzumab in this case, and again the local control at 12 months was more than 80%, and this is exactly the reason for combination, because we have also not really high, but at least we have a better control, a better progression-free survival when using both modalities versus radiosurgery alone. And again, we have the same data when we use the TDM1. So we can say that at least looking at this retrospective study, radiosurgery in some way increase significantly the local control of treated patients. And this is a recent a recent systemic review on the use of lapatinib and other HER2 target therapy like trastuzumab. In some studies, they used both whole brain radiation therapy or radiosurgery. In some studies, radiosurgery alone was used. But what is important that when we look at the outcomes of these 6 studies that were published, including more than 400 patients, in terms of survival, objective response, so overall response rate and local control, there is always an advantage of combining systemic treatments, lapatinib, or even better, lapatinib and trastuzumab, or lapatinib and capecitabine versus radiosurgery alone. What is more important, you know that there is a concern when we use radiosurgery regarding radionecrosis. In these 2 studies, radionecrosis was higher with radiosurgery alone compared to radiosurgery with systemic treatments. I cannot say why. I don't know the reason, but at least we can they demonstrate that the combined treatment is not associated with a higher risk of radionecrosis. So, just in conclusion, we know that drugs given alone, or especially when given in combination, may achieve a very good response, up to 50%. So we can say that a very good intracranial response, but we are far away from the local control that we can achieve using radiosurgery or fractionated radiosurgery, and especially when we use together radiosurgery with systemic treatments. About the timing of treatments, there are no studies addressing specifically the timing, but I have to say that most studies demonstrated that when we use systemic treatment concurrently or after radiosurgery, we have better results than those patients were treated with systemic treatments before and then radiosurgery as a salvage treatment. So, conclusion: systemic therapy have some intracranial activity, but radiosurgery should be chosen over whole brain radiotherapy for a limited number of brain mets. But you see that this limited number is now 10 mets, and probably is going to increase in the future. Based on the study, or retrospective study, this is the reason because we need prospective trials, radiosurgery and concurrent systemic treatments may increase intracranial control as compared to single modalities. Then combining radiosurgery with systemic treatments is associated with an acceptable risk of radiation brain necrosis, which is less than 10% as seen for radiosurgery alone. So if the question is if concurrent systemic treatments and radiosurgery for breast cancer are friend or foe, definitely I can say they are friends and they should be used together. Thank you.
Thank you very much, Giuseppe, in particular for this last kind of, your last slide, which kind of set the frame for the discussion. Emily, if you could join as well, then we have a joint discussion. There's quite some discussion already in the chat, so please stay and remain active. The first question to you, Emily, from Sylvia Hofer. Thanks for joining. Do you think it is surprising that the drugs accumulate in brain metastasis, where there's probably a lot of necrosis and no blood-brain barrier? The contrary is most likely true for drugs applied with preventive intent that do not easily penetrate the brain.
Yes, thank you, Sylvia, for the question. No, I think it's not surprising that drugs penetrate brain metastasis with this blood-brain barrier disruption. I think what is interesting, we also, in fact, don't want that drugs that could have a neurological adverse event penetrate into a normal brain without lesions. So there are no reasons for that. And so I think, yes, we need to have more phase 0 data, in fact, because we have seen it's difficult to know exactly the penetration into the brain metastasis. So we have seen that the CSF, it doesn't really reflect the brain metastasis concentration of the drug. So that's why I really think we need to have more data on that. And yeah, for the prevention of brain metastasis, that's more a challenge. Yes, I agree. Yeah, I'm not sure this is an option at least that needs to be, I would be more careful.
Another question, a similar direction. How about the blood-brain barrier penetration of ADCs, antigen drug conjugates?
Yeah, here again, I think we really need more data, these phase 0 trials, because it's difficult to answer. You have a lot of components into the blood-brain barrier and a lot of parameters and can vary. And it's difficult to predict. I think we really need to see the concentration in the brain metastasis. So it's difficult to say. We have a lot of things in mind, but we need concrete data, and this concrete data come from the phase 0 trials. So I think really we should encourage this when it's possible during trials, yes.
Yeah, I think it's also the rationale for combining different drugs. We know that lapatinib is a very small molecule, so probably the availability in the brain is more than TDM1, and also probably the reason because when we associate these drugs, we increase also the extracranial activity, because the TDM1 probably has more problems to penetrate the barrier than lapatinib.
Maybe a question to the both of you. Just looking at a number of trials, they're using definitions which are kind of easy to read but difficult to implement in your clinical practice. And one I find difficult is stable versus active brain metastasis. Can you give me a precise definition of what differentiates a stable and an active brain metastasis? Giuseppe and Emilie.
Okay, so but it's difficult. So well, we can say from a clinical perspective if they give symptoms or not. So that's the reason. Also because after radiosurgery is also challenging, because we see a lot of changes due to very small areas of radionecrosis, or because also after we treat with systemic treatment, we have, for example, using the TDM1 or using pertuzumab and trastuzumab, we have some changes in the lesion. It doesn't mean that they are active or they are progressing, but are just radiological changes. So it's very challenging. Usually, if I prefer to use the RANO criteria and the RECIST criteria. So if they are stable, it means they don't increase,
Emilie, for you, and we have heard about the symptoms, but symptoms that can be under steroids. So what kind of dose is the cutoff to make a metastasis stable? And what is the duration of steroids, which can be used to differentiate between stable and active? How do you apply that in your clinical practice to kind of, or don't you use that categories at all?
But I think you're right, Matthias. I think we need dedicated trials to brain metastasis patients, because we have to be sure that these lesions are really progressing, and it's difficult in retrospective to say if no MRI has been done, no MRI has been done. You cannot do anything about that. And I think that's very important. And also when you have pre-treatment by whole brain radiotherapy, which is allowed, or even SRS, but at SRS we can circumvent the problem because you exclude this target to judge the efficacy of systemic treatment, but not the efficacy of SRS, of course. But when you have done a whole brain before, and sometimes it's allowed up to 14 days before enrollment, but you look also at the effect, the combination with whole brain radiotherapy, because usually you tell us that we should not do the MRI too early after brain radiotherapy to see the effect. So, but I fully agree that we need a clear definition, and we should enroll patients with really progressing brain metastasis, and where we are sure of the diagnosis. And sometimes this is also what we do now for the recurrent glioblastoma trial. We look at the MRI before to be sure that we have a real progression of the brain metastasis at enrollment. That could be an option.
Another question to you, Giuseppe, you made a strong case of combining local and systemic therapy. If you have a patient HER2 positive and patient is on lapatinib and capecitabine, how would you kind of integrate radiation? Do you kind of stop systemic therapy? Do you go into the interval, or do you ask your medical oncologist to skip one or a couple of applications? How would you apply that in clinical practice? And if you make any changes, or the medical oncologist does any changes, what is your concern in terms of toxicity when combining it?
Okay, so we are talking about patients that was on lapatinib and trastuzumab, and then he needs radiosurgery. Usually, I don't stop the treatments. So we can do different consideration. First of all, which is the volume, which is the volume of the tumor that we treat. Second, if it's associated with a large amount of edema or not. So there are some clinical concern. Usually, I have to say that in my experience, I don't stop the treatments. I don't stop the treatment. Sometimes for larger lesions, that we have some warning about TDM1. Actually, we know that associated with the whole brain there are some, especially skin toxicity and other toxicity. But when we do radiosurgery, usually we treat 2 cc, 3 cc, and the brain is 1200 cc. So I don't expect any toxicity. So usually I don't stop the treatment.
Okay, one last question to you, Emilie, that comes from the chat. Thanks very much for the question. Trastuzumab deruxtecan is another HER2 targeted therapy which has shown efficacy in the Destiny Breast 01 study. Could you comment on the conclusion? T-DXd showed strong clinical activity in both the overall population and patients with HER2 positive metastatic breast cancer, and in the subgroup of patients with brain metastasis.
Yeah, so I think it was a phase 2 trial. And I think, yes, we know that anti-HER2 drug works. And the problem is that until now, I don't think there is a clear decision tree that does exist for the patient. And when I discuss with the breast cancer colleagues, and that, yeah, it's not, you don't know which treatment you have to try first, in fact, for your patient. But that's a nice problem to have, because you have several treatments that may work. So that's nice for the patient, but probably, yes, we need also more data, because it was only a phase 2, and the number of patients is also not so high. So I think we should continue and the assessment of these drugs, yes, and maybe compare in 2 trials, yeah.
So specifically, what was the activity in the brain? I was just looking into the overlap. So what was the activity in brain metastasis compared to non-brain mets?
So I think it was something like I don't know how many patients, in fact, exactly it was in the 2 groups. I would say it was almost the same, maybe a bit better, but regarding the number of patients, it's difficult to say that's very strong data. That's nice data that requires more confirmation, I would say.
See, but we have to remember, when we say that showed high intracranial activity, we are still these trials that compare medical treatments. So it was best than trastuzumab, but still the overall response was low compared with what we can achieve combining radiosurgery with systemic treatments. And so we expect an overall response rate about 35–40%, no more than that.
But I agree, we have to have more information on which systemic treatment we should use. But I think that would be also interesting to have more data on the combination with SRS, and not to try to do only look at the systemic treatment alone. Yeah.
I was also just looking at the data. The overall response rate was 60% in the overall population, but one has to keep in mind, as we can also see it in the chat, that the total number of patients having brain metastasis in the study was just 24. So I would say it is a quite ambitious conclusion for a subgroup of patients with 24 patients only.
Yeah.
Okay, I don't see any further questions in the chat. So thanks everyone for being active and contributing to this session. Thanks Emilie and Giuseppe for the excellent presentations and discussion. Hope that you stay on board and also continue to engage yourself here in the discussion. And with that, I would like to hand over to Michael. Michael,
okay. Thank you again for the invitation. Bye.
Yeah, hello, also from my side. We have another 35 minutes now for the next entity, so I suggest to have 15 minutes per presentation, not more, so we can have a reasonable discussion. The next debate is an intra-Zurich debate in a way, or is it Italy against Germany? I don't know. So Alessandra Curioni is now a lead figure for thoracic oncology in Zurich from the medical oncology side, and she will start it off, and then Nicolaus Andratschke will have to find counter position to that. So Alessandra, give us Italian fire.
Hello everybody, Misha, thank you very much for the kind introduction, especially this year. It's my privilege to take care of the Italian counterpart. So I will share with you my screen, and please let me know it should be already in the presentation modus. Let me just thank everybody for asking me to give this presentation.
Alessandra, can you switch the presentation mode? We see the presenter mode.
Sure. Let me just change the screen. This is kind of usually happening when we have the issue with the screen. Getting there. So that's gonna be the entire one. Let me just please give me a second, because they just changed all the settings in my computer since I was sick, and then when I came back everything was changed. So I'm gonna be here in a second, and should be in full build now.
Perfect, excellent, thank you
so much. So I would like to thank everybody for inviting me to giving this presentation. It's gonna be, I have to say, it took me a while to really be focused and find all the arguments for systemic treatment for brain metastasis and the treatment of lung cancer. I think we have, however, to say that this really is the strong collaboration between the team that is leading also to the improvement of the treatment of patients in this special setting. This is my disclosure slide. Said that, we know that lung cancer is one of the most frequent cancer, and especially is the first cause related to cancer death. And despite that, there is a clear improvement in survival over the last years for men and women. And said that this is pretty important, because when we have to take into consideration brain metastasis, we know that the incidence of such is increased by the improvement of the survival, by the years of patients surviving. So we have always to keep in mind what are gonna be the long-term as well side effects of treatments we're giving. So the incidence of brain metastasis in lung cancer are the most frequent ones. We will discuss specifically about some of these histologies, and especially about some molecular prognostic features of non-small cell lung cancer in terms of brain metastasis and systemic treatment. We know that we divide lung cancer into major subtypes: small cell lung cancer and non-small cell lung cancer. And for small cell lung cancer, the incidence of brain metastasis at presentation is about 18 to 25%. But during the 2 years from diagnosis, 50% of patients will experience brain metastasis. And at autopsy, 50% of patients have been diagnosed with brain metastasis, but a third of them were asymptomatic. So we really have to, and this is something that my colleagues in Zurich know very well, to underline the importance of MRI brain and so diagnostic in this setting. What about systemic treatment now? So there are several studies that have been performed with the use only of systemic therapy, and you will find this in this table, and some of them with a combination with whole brain radiotherapy. And we can see that the response rate also with chemotherapy can be pretty high, ranging from 22 to up to 85% in this case series. If you look, however, at the number of accessible patients, these are very few. And this is something I would like to highlight. The higher is the number of the patients included into such study, the smaller is then the response rate. So this again stresses the fact that most probably the chemotherapy might have some effects, and however, this effect is very limited. What about the current treatments for small cell lung cancer extensive disease? This includes now the addition of immunotherapy with immune checkpoint inhibitor. And to this, I cannot say much because the issue is that most of these trials didn't allow to include patients with brain metastases, but specifically with brain metastases that were not treated, which means that we also took part in such trials. We had patients, small cell lung cancer, extensive disease with brain metastases. These had to be treated and then the patient included. We know that this is not what we see in the clinical practice. Only the Caspian trial allowed also the inclusion of patients with untreated brain metastases, which, however, had to be asymptomatic. Said that, only a small proportion of patients at the inclusion had brain metastases, ranging about from 10 to 12%. So we cannot say much about the role of immunotherapy for small cell lung cancer in terms of response of brain metastases. What we can still, however, say, if we look at these meta-analyses that have been performed, is that it doesn't seem that immunotherapy would have a specific and positive impact in the patients with brain metastases in this setting. Let's talk about non-small cell lung cancer. This represents the majority of patients with lung cancer, and this can be categorized in several histological subtypes, from adenocarcinoma, squamous cell carcinoma, and large cell lung cancer, or not otherwise specified. What you can see in this table is that incidence of brain metastasis, it can clearly vary based on the histology, namely large cell, these are large cell lung cancer, from 14%, adenocarcinoma 12-13%, and less in squamous. What do we know about the use of radiotherapy for non-small cell lung cancer now, if treated in general, as it was in 2001 with chemotherapy? Well, this is the only phase 3 trial which tried to improve the response of brain metastases, taking into account patients who received chemo and radiotherapy upfront, or patients who received only chemo upfront, and radiotherapy would have been allowed afterwards. So the primary endpoint of this study was to look at the response rate of brain metastasis, and as you can see here, there was no significant difference in the two groups. Keep in mind that this is a study of 2001, and here patients have been treated with chemotherapy independent of their subtype of histology or molecular subtype. To date, we know that, especially for adenocarcinoma of the lungs, the molecular alterations are the one that dictate the biology and the therapy of these diseases. We can see a very nice overview of mutational analysis performed in early stage lung cancer and in late stage lung cancer, and the occurrence of the several molecular alteration. I promise I'm not going to go through all of this subpopulation, but just to give you an overview, this what we were mentioning before is that the biology, so the molecular feature, can change also the biology of this disease, and this we can clearly see also in the incidence of brain metastases in these different subgroups. If we know that KRAS is one of the most frequent one, we have, however, to say that most brain metastases would occur in patients with ALK or ROS1 positive tumors. And why is that so important? Because all of these different molecular alteration will lead to the possible access to targeted treatments. How this impacts now the brain metastases and the treatment of those. Let's start with EGFR, which occurs in about 15 to 20% of the patients with adenocarcinoma of the lungs? Well, several drugs have been developed over the time. This is an evolution of all possible targeted therapies, getting up to osimertinib. And the response rate to these different drugs, you can see here from gefitinib, erlotinib, afatinib, and osimertinib, ranges with a response rate intracranial from 10 to 88%. This is very important. This has been crucial for the development of the latest generation of EGFR inhibitors. And why that? Because improving this drug has improved dramatically the overall survival of these patients. And we can see that with osimertinib compared to other EGFR TKI, but also has improved the CNS progression-free survival. Again, this is from the same study, the FLAURA trial. So osimertinib has clearly shown an advantage in overall survival and CNS responses. Said that, when we look now at all the data that have been performed retrospectively or in the previous years, before previous data of osimertinib, we have to reconsider all the data we look at. And specifically, there are several studies that have either retrospectively or looked at the population of patients with EGFR mutation, which underwent treatment with TKI, but also whole brain radiotherapy or a stereotactic radiotherapy. And one of the fewest ones showing an overall survival benefit with patients who received the same time also radiotherapy is the study here for Magnusson. But if you look at it, this study, first of all, had all patients receiving the older generation of EGFR TKI, and most of these patients had only intracranial disease. Therefore, to use this study, it's not anymore actual. So we cannot use it anymore for the population of patients we see now. So there is a clear need to look at future trial with the newest drug. And this is also true for ALK. ALK translocation occur in about 5% of non-small cell lung cancer patients, and there have been several drugs developed, these ALK inhibitors over the time. I will never forget when I was participating to the investigator meeting of this alectinib drug and using alectinib drug, because they were explaining how the drug was developed to be efficacious for brain metastasis. And you might recall that patients with ALK translocated tumor have in about 30 to 40% occurrence of brain metastasis. Now, if we look at the intracranial response rate of all these different drugs, from the very beginning one to the latest developed, we can see a difference in response rate from 27 up to 73%. And we know that now alectinib has also translated the way and changed the way we treat patients in the very first line setting with ALK-positive tumors, with the use of alectinib in first line instead of other generation treatments, because of a clear benefit in terms of overall survival, but also because the incidence rate, and this is what you can see here on the right side, of CNS progression was significantly reduced with the use of alectinib versus first generation. Now, this is still very important because if we take into consideration patients who have previously already started with other ALK inhibitors over the time, what we should expect? Well, we have performed a very broad analysis with more than 140 patients with ALK-positive tumors in many centers in Europe, and looked specifically at what is influencing the most the outcome of this patient. And certainly what it influences the most the patient's outcome is the use of more than one TKI. So having available more than one of such TKI, it can certainly positively influence the outcome of these patients. Now, for this reason, also the NCCN guidelines came up to this conclusion that if there is a reasonable systemic treatment option for ALK or EGFR positive non-small cell lung cancer, it is reasonable to hold on treating radiation therapy and see if systemic therapy can control the brain metastasis. What do we do in case of non-oncogenic driven non-small cell lung cancer? Well, in this population of patients, we base ourselves on the expression of PD-L1, which is an immunomodulatory molecules that might inhibit the immune system, and we treat patients with chemoimmuno or immunotherapies. What are the challenges of using immunotherapy for brain metastasis? There is this wonderful study published in 2019 in Annals of Oncology, which compares the tissue immune microenvironment of brain metastasis and primary tumor, and it could clearly show that there is an immunosuppressed tumor microenvironment with tumor-associated macrophages, reduces CD8 T cells, and TILs infiltration. Therefore, this is one of the major challenges of using immunotherapy for this population of patients with brain metastases. Another important challenge is that there is also the difficulty of excluding pseudoprogression. This is a study that we performed at our center, looking at patients who were under immunotherapy, where progression was detected in MRI, but we could then specifically look with the use of FET-PET and define and detect pseudoprogression. So that if we look at the intracranial responses of with patients undergoing immunotherapy, we have to say that very few patients with brain metastases have been included in such trials. However, some intracranial responses have been seen. Probably, again, resembling what Emilie was talking about with the alterations of the blood-brain barrier in case of brain disease. There is this very nice chart that is depicted by Santa Maria and others in clinical cancer research last year, how to treat patients with limited brain metastasis or extensive brain metastasis in case of good condition and undergoing immunotherapy, and suggesting the use of eventually stereotactic radiotherapy and otherwise whole brain radiotherapy. This I have to say, however, is a chart that resembles what we do into the clinic, but we really still need clinical trial, prospective clinical trial to address this question. And there are several ways by which immunotherapy is going to work and is going to be used for brain metastases. Last but not least, just one chart on KRAS mutations, which is one of the most frequent one in patients with adenocarcinoma of the lung. And we know there have been developed several drugs targeting this specific mutation of KRAS and with very important responses. And I wanted to mention it because just in the night between yesterday and today at the World Conference on Lung Cancer, there was described the intracranial disease control rate of patients with brain metastasis undergoing this drug. So we have to, would like to keep this in mind. There will be several trials specifically for patients with this mutation, KRAS G12C, with several combinations for patients specifically with brain metastasis, and many drugs are to come for this specific disease. I come to my conclusion slide, and patients with brain metastasis should be included in clinical trials. It's important to say that this should be, in my view, also a stratification factor for targeted trials. And what I again would like to stress is the quality of life of these patients should take into account the possibility of longer overall survival. New treatments are in development with several immunomodulators, and the synergy with radiotherapy for brain metastasis with all this new treatment to come needs to be explored. By this, I would like to thank you all very much for your kind attention, and I'm looking forward to hear Nicolaus Andratschke.
Exactly, Alessandra, that's what we're going to do. If Nikki can come out of the shadows, and we have no questions anyway, we do that afterwards. Nikki, so Nicolaus Andratschke is the vice chairman at the Department of Radiation Oncology here. He is a Bavarian, spent a lot of time in Munich, made a little trip to the north, to Rostock, and has joined us when Matthias Guckenberger came to Zurich. And now, Nikki, it's all yours.
Thank you very much, Michael, for this kind introduction and also giving an outlook to my short past. Before I head into my talk, I would ask for the question. And I've prepared two questions, and we put it in between the talks. So you heard the systemic point of view, and now you will hear the radiosurgery point of view. And maybe you could pull up the question again. So the first question is about a 60-year-old female patient, curatively treated for a adenocarcinoma, and now a couple of years later she develops 6 asymptomatic brain metastasis with an EGFR mutation. So what would be your first choice in this case? And we have a lot of upfronts, but be careful, sometimes it's upfront targeted treatment, or it's upfront radiosurgery, or upfront whole brain radiotherapy. Again, radiosurgery. Okay. Silke, I'm not sure if everybody has answered. Okay, we see the answers right now. We will immediately switch to the second question and then see how it changed over my talk. So there were predominance of the first two answers. Maybe just pull up the second question, please. We have a different case with a 55-year-old male with a primarily metastasized non-small cell lung cancer. Again, 6 asymptomatic metastasis up to 10 millimeters, but this time with a PD-L1 expression of around 20% with additional extracranial disease. What would be your first choice? Again, a lot of upfronts. And let's see how we can change this picture after my talk. Well, actually, I don't want to, because that's a very nice result. Okay, now sequences of SRS and systemic therapy in lung cancer. And first of all, I would quickly introduce you. Thank you. Well, these are my disclosures, but I would like to introduce you quickly to the concept of upfront. What does upfront mean? Upfront really means what treatment comes first. In this case, upfront radiosurgery means you do the radiosurgery and then you start your systemic treatments, or you have a close overlap. But there's also the other possibility. You start your systemic treatment, and within a certain period of time, and that's mostly 4 to 8 weeks, you can call for another MRI, and you just treat on demand early if you have persistence on the MRI. And of course, you have the delayed, where you start out on your systemic treatment, you have your follow-up, you have your CMRI follow-up, and only if you have progression or you have the development of brain metastasis, then you give radiosurgery in this delayed fashion and delayed manner. Now, why would we need upfront or earlier radiotherapy? And I will just walk you through very bold statements I made up for upfront and early and the different treatments. So I think with these are two quite nice, although retrospective studies, looking at the response of the brain metastasis and the time to partial response. And these are considering upfront radiosurgery and the timing of immunotherapy. And what we see is that with the concurrent versus the non-concurrent approach, meaning you start with your radiosurgery immediately, you just have a faster time to partial response, although the dose was slightly lower than in the non-concurrent arm. The steroid use was similar. Here, another study where it's chemo versus IO, and in the combination with IO, if you give it up front, you have a quite fast time to partial remission as well. And interestingly, the larger the metastasis, the larger the response rate. So maybe the early administration of radiosurgery provides a symptomatic benefit if you have symptomatic brain metastasis. And even though if you want to have durable local control or long-term outcome, this might be of benefit as well. Well, and you might also have smaller volumes you're irradiating, because not every patient is responding in the respective time. And this is just a study that's like a surrogate. This group looked at the diagnostic images where the brain metastases were diagnosed, and then at the time point when radiosurgery was performed, and that was around 3 weeks later with a quite large range. And although this was only 3 weeks, already 80% experienced a volume increase. And this volume increase was also up to 40% in 1/4 of those patients. So maybe this is another indication that you do not only want to wait until you treat the brain metastasis. Well, the upfront discussion gets a slightly different twist. If we look at targeted therapies, there we might give it another approach. And that's actually a study that was not only looking at brain metastasis, only a minority of those patients had brain metastasis, but they generally looked at how fast and when the optimal response to targeted therapy was happening. And they found that the median time to shrinkage, maximum shrinkage, was around 2 months. That's actually the interval we would recommend for the early delayed radiosurgery looking for persistence. And still, and interesting, if you look in the long run, up to 40% had a progression at the initial tumor site. So if there's progression, it's at the initial site, so local control doesn't matter in this population. Of course, with this approach, we again see 20% increase in size in some of those patients. And we need to be aware that not all patients are fully responding. So local therapy still may have a place here. Now, it's not only about the size we are treating, the local control we want to achieve, but we also look for the outcome. And this is a systematic review of the literature, where we see that we have an improved local control, we have an improved brain progression-free survival, but also an improved overall survival if radiosurgery and immunotherapy are given concurrently. Of course, we have seen the slide yesterday, retrospective data, but at least it's hypothesis generating in this context. We have a similar situation with targeted therapies, also a systematic review where we see that that these studies, or this study concluded that early administration, in this case upfront administration, favors the combination treatment and not only the upfront targeted treatment, and then the wait and see strategy. We need to be careful. This study, or these studies, are still having a lot of patients receiving whole brain radiotherapy, which we, or I, consider not as effective locally as radiosurgery. And these studies did include mostly EGFR targeting therapies from the first generation or the early generation. We now have next generation targeted treatments. Here, a study that mainly included patients treated with osimertinib and alectinib. And here, if we look at the treatment, the time to failure in this population, that actually corresponds to the overall survival outcome, although a very small cohort, there was no difference observed. Quite conflicting, another study with much more patient and osimertinib only treated population found an overall survival benefit of the upfront radiotherapy treated patients. So here certainly, or again, retrospective data, but again, it's in line with the Magnuson paper originally, and the jury is still out, and we need the respective data to confirm this. Another very interesting aspect is that a lot of the patients, or a lot of the studies up to now, of course, that's improving, a lot of those studies were excluding patients with brain metastasis in their IO or targeted treatments. And I think that's a very interesting concept that is promoted by Sperduto et al., this kind of eligibility quotient. So you have your prognostic score, you look at your survival probability after radiosurgery. So at the time after radiosurgery, you look at the probability to survive 12 months later, and you divide it by the survival probability predicted by your score. And then if the quotient is greater than 0.5, meaning the patient has a greater than 50% chance of surviving the next 12 months, you could include him in a study. And that's depicted here with the disease-specific GPA. So in the lowest category, patient that maybe had received radiosurgery 6 months earlier will not be eligible, but a patient in a very good prognosis GPA class may still be eligible for a trial. And I think this optimal treatment of brain metastasis may increase trial eligibility, and we should consider this as well. And we calculated that based on a score in our own cohort, and that's quite interesting. This is a highly selected radiosurgery population, but even in the worst category, if a patient survived 12 months, the probability that he might survive the next 12 months was quite high. So I think we need to reconsider how we include patients in our trials. Now, when should we consider delayed radiotherapy in non-small cell lung cancer? And these are very general statements that may be not only applicable to non-small cell lung cancer, but in general. But I took the data that we gathered, and we also already saw this figure. If you look at the local control, that's very nice. And these are all patients. Well, if you look more specifically at patients that only survive 2 years, local control is a little bit lower because we have limited competing risks. But just remember the 90% local control. And if we now look again, just by calculating the survival probability based on the KPS performance status in a 3-tiered score on our data, we just see that if we look at 12 months survival probability of patients with a Karnofsky performance status of 60 and less, it's less than 25%. So why should we give a treatment with a high local control probability if we don't need the local control because the patient is not surviving long enough? On the contrary, in the other two groups, these are treated patients for their brain metastasis. Yes, there it might make sense. So if the life expectancy is shorter than the duration of local control, maybe we don't need local treatment. On the other hand, we heard a lot of the targeted treatments, and we have disseminated brain metastasis. Here, a case with more than 15 brain metastases of differing size, up to 1 to 0.5 centimeters. And yes, if we look at the data, how long the median overall survival with targeted treatments nowadays is, so probably in those patients, we can omit whole brain radiotherapy in the first place and replace it by delayed radiosurgery upon progression. And yes, I think the question of early versus delayed has been superseded recently by the concept of this repeat radiosurgery approach in a population where we have effective systemic therapies and which then progress in a confined manner, not all the time in an oligoprogressive or oligorecurrence manner, but at least in a confined space manner where we are able to locally ablate the tumors. We have now retrospective studies showing quite good results. One point is to avoid whole brain radiotherapy, which we were able to achieve, but reasonable overall survival after the second course of radiotherapy. And maybe this is a nice strategy to keep patients on an effective treatment extracranially, but put them on repeat local treatment to avoid a switch to the next line of treatment. And with this, I already come to my conclusions. In the absence of prospective trials, for all the bold statements I made, I would conclude that upfront radiosurgery should be given or considered for oligometastatic disease, brain-confined recurrence or progression that is suitable for radiosurgery, of course, for symptomatic brain metastasis. And I told you that maybe limited life expectancy and asymptomatic multiple brain metastasis could be a reason to delay it, especially if we have extracranial progression and drugs with brain activity available. And yes, a nice approach is the deferral of switch to next line of systemic therapy with this delayed but repeated radiosurgery approach. Thank you very much for your attention. I'm happy to take questions and also pull up the questions from before and see whether we have a change there.
Thank you very much, Nikki. Here's your question again. You want to ask it again?
Well, maybe I quickly rephrase it. It's a 61-year-old female patient, initially curatively treated for locally advanced node-negative adenocarcinoma, now presenting with 6 asymptomatic brain metastases up to 10 millimeters, and the initial mutational status was EGFR mutation. And how would you deal with this patient? Either upfront osimertinib or upfront radiosurgery, whole brain radiotherapy, or the different combination of that. Okay, maybe we just quickly can keep that. That's interesting how this changed. Maybe a few more people have joined the meeting, or I'm not sure, but here it's upfront radiosurgery followed by osimertinib. There the picture initially was slightly higher for the first approach, but now this is dominating. Okay, maybe we can go to the next question. And that's very interesting in this case because that patient from the case did not have extracranial disease, but still we feel that, or the participants feel that systemic treatment is necessary. Here we have a patient with primary metastasized cancer, intracranially, extracranially, with 6 asymptomatic brain metastases, again, up to 10 millimeters, this time with a PD-L1 expression of 20%. What would be your recommendation to the patient? Either upfront IO, upfront radiosurgery, upfront whole brain radiotherapy, or a combination of both with an early or delayed. Okay, that's also slightly changed so that we had 100% before, but we also have the situation of giving upfront IO first and then following active surveillance. Maybe I made a too strong a case of the early delayed treatment, but I think that's exactly what's currently under debate. But here we see this early delayed as 13%. So only that's a very interesting change. Thank you very much. And I'm open to question if there are any in the chat.
So now we have eaten up already the discussion time, but I think I steal 1 or 2 minutes. So there's one question in the chat that I like, and I think you see that, Nikki, right? If you give more SRS earlier to more patients with more lesions, maybe these retrospective unplanned analysis will be even less positive in the future. Short answer, please.
Risk benefit.
Well, Nikki, if you start treating patients with 10 lesions that are bigger, then maybe the survival advantage that some people perceive to see will not be as prominent anymore.
Well, well, it all depends whether or not we consider the intracranial control as a relevant endpoint, if it affects neurologic death as well. So and that's one thing. And the second thing is we are pretty advanced with this repeat radiosurgery. So I'm not that much, and we have a very vigorous, well, follow-up procedure. It's rather a screening procedure for new lesions. So I'm not sure whether this will impair here in this situation, but we will just have an earlier salvage.
Okay, so Nikki, quickly to your last slide. I mean, that I think it's a very radiation-driven new invention of an endpoint that you call, what was it? Was very nice. You defer the switch to the next systemic treatment. Yeah. What I think is what you're doing is you are helping people to maintain a systemic treatment that doesn't work by giving repeat radiosurgery, right? Isn't that the truth, what you're doing?
Well, this may be true in a fraction of those patients, because currently we cannot fully answer this, but we have, at least for the driver mutated patients, we have quite interesting analysis if we consider patterns of failure and pattern failure in the TKI only treated lesions. And it's very interesting to see that the pattern here is really first of all, oligoprogressive, and especially in the initially present lesions, either the primary or the metastasis. That's why I don't think that we're deferring the switch to the next effective treatment, because they are really oligoprogressive. And we also have data that at least also the newer targeted drugs are able to reduce the incidence of newly occurring lesions, and therefore it's certainly predominantly the resistant clones that are appearing. So
I would like to give that question also to Alessandra.
Yeah.
And Alessandra, if you have patients that have benefited well from systemic treatment and then develop brain mets de novo, are you comfortable keeping patients on this systemic treatment?
Yeah, if we have extracranial response and continuation of response extracranial, I would say absolutely yes. And moreover, if the patient is on immunotherapy, so we had often the case of patients with several and recurring brain metastases on immunotherapy, and at a certain point, after 2-3 years, they stop to recur, which probably might also reinforce what it would be the local immune responses on a patient who is on systemic immunotherapy and receiving the local radiotherapy. So by this, I would like to underline the possibility of a synergistic effect intracranial. So for both reasons, I would say absolutely yes.
Okay, so I think we still have a lot of debates here, but it's we have now 5-10 minutes over time. Maybe we can pick up these topics again also for the melanoma field. So I thank you both, and then we switch to the next topic, and this is melanoma. And I hope Hussein is yeah. Hello. Good evening. Thanks for joining. Where are you?
I'm at my home in Houston, Texas, actually.
At home. Okay. So yeah, I guess many know our friend Hussein Tawbi because he was also a visitor at our last real meeting that we had, and we enjoyed his visit a lot. He's actually from Lebanon and got also part of his education there, and somehow managed to get from Lebanon to MD Anderson, which I think is more than a little culture shock, but everybody knows you survived it well. And obviously you are one of the protagonists of systemic treatment alone. So we give you the floor for 15 minutes of your position. Thank you so much.
Thank you so much for the invitation. Great to see you, Michael and Matthias, and I will also say a very quick hi to my good friend Reinhard as well. And thank you so much for the invitation. I really did enjoy my time a lot last time I was in Zurich, and really enjoyed the presentations before me. I really appreciate the setup. You know, Matthias set us up in a way to actually debate quite vigorously, and it's really interesting to see kind of the different perspectives. And I think all of our conclusions at the end are going to be, we need to continue talking to each other. So I'll actually just summarize the systemic therapy for melanoma brain metastases. And as you've heard from some of my colleagues, just giving you the melanoma perspective here. Melanoma actually has an incredibly high propensity for brain metastases. We know that at the time of stage 4 disease, we actually have up to 40% of our patients that have brain metastases. So actually a screening MRI is part of our staging for stage 4 disease. And autopsy series have shown that patients at the time of death, 80% of them will have brain metastases. So in 2011, this is a data from my colleague Mike Davis that showed that the 1-year survival is less than 20% for that population. Of course, in melanoma, we've been very lucky to have had tremendous progress in the last 10 years, and we've seen our overall survival go from 5%, and now we have 12 different approvals. The most recent data is actually, which I'll share with you, is that the 5-year overall survival is more than 50%, so a 10-fold increase in the survival of our patients. In fact, looking at the data that was just presented at ASCO, we now update our data in half years. So in a 6.5-year overall survival from Checkmate 067, we finally have a median. The overall survival crossed the 50% mark at 78 months, or 72 months to be exact. So our patients are, essentially cured. Up to half of them are essentially cured. We're even, become cocky enough that we actually look at melanoma-specific survival. As you know, overall survival accounts for all other causes of death. And the truth is, less than half of our patients are dying of melanoma. So 56% at 78 months are alive, and technically their melanoma is controlled. And I'm really excited about newer therapies that continue to come along. And you might have seen this at ASCO with relatlimab being a new checkpoint inhibitor that has shown benefit already over a single agent PD-1, a lot safer drug than our combination, than the combination of Nivo plus Ipi. But this particular study, another phase 3 pivotal trial that is likely to lead to an FDA approval, is also lacking in a very important context, which is the fact that every single one of those studies that are phase 3 registration studies exclude patients with brain metastases. So I keep updating the slide with every new phase 3 trial, and now we're up to close to 8,000 patients, every single one of them weeded out to not have any active untreated brain metastases. And so on the right, I've included the entirety of all of the data that we have in the field, which is, quite significant. And we'll go through some of that data. These are studies that are designed for patients with melanoma brain metastases. And I have targeted therapy, I have single agent checkpoint inhibitors, and then combination checkpoint inhibitors. So around 775 patients worth of data that really still informs our practice. And that's what I'm going to share with you. So I was asked to stand for why systemic therapy first. You will know towards the end that I'm not necessarily completely focused on only systemic therapy. But again, our melanoma context is that we know that only about 10% of patients have brain-only disease. So more than 90% have concomitant systemic disease. You saw a really nice slide that I didn't include from Emilie showing how in melanoma, the neurologic death from brain metastases is quite significant. The other thing that we'll share with you is that the responses with systemic agents can actually happen really early. So we'll go through over that data. They happen in more than 50% of patients. So we do have some significant benefit there. And I will actually argue that by shrinking intracranial tumor, and I think that will lead to some debate, we actually help you guys in radiation oncology. We decrease the volume that you have to treat. So perhaps it'll become more effective and perhaps less toxic with radiation necrosis and others. So there is a lot of value to starting first. Now, what is the data to support this? I think this is probably one of the most iconic images in our field, which is the first responses from dabrafenib, a single agent BRAF inhibitor, in the brain. And you can see how these responses can be quite dramatic in patients with BRAF mutated melanoma. Now, the interesting part is, the standard of care in melanoma has moved very quickly into combination therapy. So combination of BRAF and MEK inhibitors, dabrafenib and trametinib. Together, they have an extracranial response of about 60%, 66% to be more exact. What you see here is waterfall plots for intracranial disease. And this study had 4 different cohorts. We're not going to go into that too much, but the response rate intracranially was close to 60%. So slightly lower than extracranial, but not by a lot. And the interesting part with the study is we've learned very quickly that it does induce, targeted therapy induces quick responses. And as you saw, pretty deep responses, but the duration of response is limited, is actually shorter than the duration of response outside the brain. So if you see here on the right, the median PFS for extracranial disease is 10 months, but for intracranial disease, it was only 5.6 months. So there is something you lose towards the end, but you can get the quick responses. And when they looked at where was the progression when these people progressed, 75% of the time it was intracranial. So obviously there were some people that had intracranial plus extracranial, but 75% of the time included intracranial progression. So we do lose control of targeted therapy in the brain within about 6 months. Now with immunotherapy, this is single agent. So I included on the left, what would you expect in patients without brain metastases? The response of single agent IPI is about 15%. The responses are durable. On the right, you see the cytokine working group trial that was led by Kim Margolin and showed that single agent IPI looked, and for patients with brain mets, looked exactly the same as if they had no brain metastases. The only difference, so the response rate is a 10% durable responses. The only difference in these two curves is the curve that's below, the blue curve that didn't show a good outcome, is patients that were treated with IPI that were on steroids at the time of initiation of immunotherapy, and they had almost zero response and they progressed really quickly. So that's an important lesson from this particular study that we're going to come back to in a second. With single agent PD-1, we have data from Harriet Kluger from Yale, which showed that, again, outside the brain, single agent PD-1, about 40% response in melanoma and durable responses. In the brain, and this is only 18 patients, and the response intracranially was, there were responses and they were durable, but it was only about 20%, 22%. So perhaps slightly lower than what you would expect with single agent PD-1. And so when we look at IPI and Nivo as a combination, without brain metastases, you get extracranial response of about 57%. I consider it our most potent immunotherapy, but also pretty toxic. So 55% of patients will have immune-mediated side effects, and we know that they have 2 or 3 side effects, so not just one. And this is the kind of lesions that we treat. You know, Checkmate 204, I think when we present it, I hear a lot about small asymptomatic brain metastases. This was a patient that was on that study, treated actually at Moffitt Cancer Center. You see the size of the lesion, you see how much edema around it. This patient did not require steroids at the time of initiation of therapy, and here's the response a year later, almost a complete response. And this doesn't happen in one patient, it's happened in almost 55% of patients. So this is your waterfall plot, and you see that in this waterfall plot as well, we have a bunch of CRs. In fact, about half the responses were CRs, complete responses, 29% out of the total 55%. So half the responses were complete. The median time to response, about the fact that it was quick. So the first time we checked the brain was 6 weeks, so 1.6 months. And the first time we checked, we had already an objective response. And then 87% of them are durable. Unfortunately, this meeting is exactly a week before ESMO. I can tell you that at ESMO, we're going to present kind of longer term data. So you may have seen this already, but we're going to show in about a week the fact that, you know, this continues to be a really impressive PFS for this population, both intracranial and extracranial. And that's, going into, translating into overall survival. Now, the interesting part is absolutely, this is a population that was asymptomatic, at least had to stop steroids 10 days before they initiated immunotherapy. And obviously, we know that is not what most of our patients do, and we can discuss how often people start steroids, sometimes unnecessarily. But for the patients that were either having symptoms or were on steroids, we felt that that was kind of the next important question in the field. And sure enough, we updated or amended the study to include a cohort B, which allowed patients to be symptomatic, had a PS, a performance status of up to 2, and 4 milligrams of dexamethasone. And we treated those patients and we got responses, but it was not as good as if you had no steroids on board. It was only 20% response rate. And when we looked more closely, it was really the patients that were on steroids really did not respond. It was only a couple of responses if you were on steroids. If you were only symptomatic, we still got responses in the population that was symptomatic. But again, when you get an intracranial response, it is durable. So despite the fact that this is a much smaller proportion of response, the patients that did get it had a good outcome longer term, PFS and OS. Our same data, similar results were obtained by the Australian group. I'm only sharing this not to be redundant. It's about the same, answers here. 35 patients with ipi-nivo, so it's a smaller population with ipi-nivo than the 100 that we treated, or the 118. But they also had an interesting cohort. One, they had single agent PD-1. It had the same outcome as the Harriet-Kluger study, but they also had a cohort that was symptomatic, leptomeningeal, really bad prognosis patients treated with single agent PD-1. And the outcome in that population in cohort C was really dismal, as you would expect. Single agent 20%, like you've seen with these with the Kluger data, and then the IPI and Nivo together was exactly the response rate that we've observed. Again, responses that are durable, as we've discussed. And so the question now is, where are we in the field? So we're moving forward. First, I think one of the most important aspects is we want to increase efficacy. We want more effective stuff than 50%, but we also want to decrease the toxicity. So I can tell you, using lower doses of IPI has been considered in melanoma. It looks like it may work just as well for extracranial disease. So we're asking the question, does it work in the brain just as well? We don't know that. And I think triplets are very important. I'm not going to go into the extracranial disease triplets. It's a longer discussion, but the idea of adding PD-1 to BRAF and MEK inhibitors, supported by a lot of preclinical evidence and retrospective data. And now there are 2 phase 3 trials that show one of them was negative, one is positive. We think there is a value to the triplet, so we are using it in the second line, and I'll show you data from our study there. But we're also looking at the triplet in the first line. That's a study that Reinhard is leading, globally, and I help him in that study. Hopefully, we'll see results from it soon. And there's also a study in SWOG where we're actually comparing the triplet versus ipi-nivo as a combination. That's S2000. So there may be value to triplet therapy. We're looking at it. I can tell you from our population, we had about 27 patients. And the patients that you see here in red are PD-1 refractory. The patients that you see with asterisk are patients that had active untreated brain mets. And we had about a 67% response rate. I think most importantly, the PFS was the same in the brain and in patients with brain mets and outside and no brain mets. So kind of indicating that perhaps adding PD-1 kind of takes away that short duration of response that the dabrafenib and trametinib has. So we're kind of trying to follow up on this data, and we think it's kind of relevant in the field. But again, second line, not first line. So other things we're looking at. So other combination therapies, we're combining atezolizumab with Avastin and cobimetinib. So it's a study with a MEK inhibitor. We're looking, and I'll talk about the MD Serono study in a minute, because I think it's interesting because it's not melanoma specific, and obviously can't wait to get Nivo-Rela. So we have that study, Nivo-Rela for the brain, will be ongoing at our center in the next couple of months. So this is kind of how I think about it for our patients in MD Anderson. We think about whether they're received immunotherapy before or not, whether they're PD-1 refractory or not, and whether they have BRAF mutations or not. And we have a strong L&D program that I won't be able to cover in my 15 minutes. But then the question that you asked me to address is, what about SRS? When do we use SRS? And, I kind of like the fact that Matthias started with that lively correspondence, to the original paper from Georgina. And we had similar correspondence when we published our New England Journal paper, and kind of really, I think the field needed to think about the fact that when we try to bring things to the first line for brain metastases, we're not necessarily trying to replace, we're trying to find newer options for our patients that need to be treated. And there's a lot of reasons. We've heard a little bit about synergy. I can tell you this was one of the first trials that, or retrospective studies that showed IPI was so impactful on patients that have had IPI plus SRS, did a lot better than patients that did SRS alone. This is, again, melanoma brain metastases. And there's a lot of reasons to think about that. I'm not going to go too much into the science. All of you probably know this way too well, but the idea that immunotherapy or radiation therapy can really be synergistic and produce an abscopal effect, and there are so many mechanisms to consider for why that would be the case. I did see the comment about the role of fractionation. I'm happy to discuss this in the discussion piece. But I really want to say that all of this data, great data that is starting to come out and show us that, it might be best to combine. The problem is it continues to be retrospective, and we don't have in hand a very good prospective evidence that combining immunotherapy with SRS is an effective approach. I'm really interested in the timing question. I always show this particular study that discussed concurrent versus non-concurrent and whether you should combine them up front or not. Concurrent here was defined as being 4 weeks between immunotherapy on target and SRS. And you know, clearly, as you see in this, there seems to be better outcomes with concurrent therapy. I think there may be another answer to this that we'll discuss. We cannot ignore the fact that combinations may lead to a higher incidence of radiation necrosis. So this has been reported in multiple trials, but I'm just showing one here, or retrospective studies to be specific. I'm showing here one that shows that the incidence of radiation necrosis with immunotherapy is significantly more than without immunotherapy. But I also will point out the fact that obviously the other predictors of radiation necrosis is the size of the lesion, the number of lesions treated, the overall volume. So there should be consideration for whether if we use immunotherapy, we could actually improve some of these other factors that are predictive of radiation necrosis. So I can tell you what we do at MD Anderson to address this problem is we never make our decisions on our own as a medical oncologist. So we've created this brain metastases clinic where myself, Fred Lang from neurosurgery, and Jing Li from radiation oncology basically come together, see the patients together, and make a decision on what would be the best sequence of events. And we obviously have, we're starting to develop clinical trials around that. So this is the EMD Serono trial that I'll discuss briefly. But here's the cast of character, an incredibly talented group. And again, we have 9 medical oncologists, about 4 or 5 radiation oncologists, and 5 neurosurgeons that we do this 3 times a week on Mondays, Tuesdays, and Thursdays. And this clinic has been kind of a central component, and we're building research around it as we take these patients to the clinic. A really important one that I want to bring up and just hopefully be part of the discussion is the study of the MD Serono MEK inhibitor, pimasertib, in combination with the PD-L1 TGF-beta bispecific. So we actually designed this. I designed it with Jing Li. And the idea here is we give 2 cycles of treatment. We follow the patient with a brain MRI very closely, like the first 4 weeks. And then we have a planned SRS at 8 weeks. And the idea is the patient will be seen. And then we will, the idea is that we'll do the SRS for only the lesions that are not responding or progressing on treatment. So if your lesions are shrinking in response to immunotherapy or targeted therapy, to systemic therapy, maybe you can spare those lesions that are shrinking and actually just treated the progressing lesions. So I'm sure that's going to be a lot of fodder for debate, but at least one idea. So not combine everything up front, not wait for salvage, but treat what needs to be treated. And so in conclusion, I think, I've shown you that in melanoma, we know that targeted therapy can be safe, can be effective. We know that we have a lot of work to do to improve the efficacy. As somebody said earlier, 50% is still lower than 75%. I think the optimal sequence will require prospective trials, if not randomized, at least prospective. And that we really believe in the multidisciplinary decision-making. I almost never make a single decision on one of those patients without bringing them to the brain met clinic and discussing with my radiation oncology colleagues. And I think that would be the way for us to accelerate drug development in general. So I'm gonna stop here. A bunch of people to thank for actually being able to present any of this data and for the brain met clinic as a concept. So with that, I'll stop sharing, and I'll be happy to address questions and to listen to Dr. Combs as well. Thank you.
Thank you so much. Very interesting data. I think if Stephanie is ready, then we have her first and then discuss it together. Hello, Stephanie. Stephanie, we know for a very long time. She spent most of her professional life in Heidelberg and was very active there in the neuro-oncology program. And a few years now, she is at one of the 2 universities in Munich, the Technical University, and leading the radiation oncology program there. She's also the new chair of NOAA, as far as I know. Congratulations. And we wait for your talk.
Thanks, Michael, for the introduction. And yes, indeed, I think we've known each other since one of the first days I started after medical school. So we have a history in that. And I want to thank you and also Matthias for organizing this symposium and for inviting me to contribute on from a radiation oncology perspective. I really enjoyed Hussein's talk because he made a couple of points in favor of radiation, which is really nice. And it makes it easy for me because I can just sort of echo what you already said, enduring local control, response rate, and things like that. But also one thing you already pointed out that I'm also going to touch on why we are worried about combining radiation and immunotherapy or targeted treatments. It's this radiation necrosis edema issue, and then the discussion, do we need to give steroids? But in the end, first of all, the data for that is inconsistent. I'm going to point out that later. And secondly, you also already pointed out that the main risk factor for the development of radiation necrosis or edema, it's probably not the immuno or targeted therapy, it's probably really the volume that we treated. So in the end, if we do these prospective trials, and I totally agree, we need to do them. It's not just saying we include patients with 1, 3 or more brain mets, but it's really looking into the parameters of volume, of radiation parameters. And the difficulty is that most pharmaceutical companies are not really interested in those questions. But now let me get back to radiation and to the question we're actually wanting to address. And I'm just going to echo some of the basic data why we are discussing this issue, because basically we could say, well, some issues are solved. Yeah, we have a patient with brain metastasis, we can treat them with surgery, we can observe them, we can do whole brain, we have all that data out there, and all these treatments are established, they're safe, and we have these options available. But I think we have some main issues that make it difficult in our daily treatment decision. One is if we look at this yellow curve, we might have a patient that is treated by surgery. Then what do we do afterwards? Do we just do systemic treatments independently if it's a lung cancer or if it's a melanoma? Or do we have to do local treatment because this yellow curve shows us that after surgery alone, the brain met will come back in about 50% of the cases within half a year or a year. So this is one of the questions we have to discuss from a radiation oncology perspective. What do we treat? How do we treat these patients? Is it a local treatment we do after surgery? Is it maybe whole brain if we have other multiple mets? Or is it a treatment to the surgical cavity? And all of those decisions in the end do have an effect if we combine with systemic treatments. And this has been addressed by the questions that we have seen in the chat room, asking us, are there differences between single dose and immunotherapy? Is hyperfractionated maybe better? How do we best enhance an abscopal effect? And so on. And so if we look what radiation oncology has available to treat patients with brain metastasis, we have several concepts beyond just doing radiosurgery or just doing whole brain radiotherapy. One concept that is emerging at the moment, I think it's a very nice concept, is the concept of neoadjuvant radiosurgery. And I think this is something especially important in those patients who are metastasized outside of the neurocranium, and patients that do have a radiation-resistant histology, such as melanoma, because you can sterilize the surgical area, you don't need any adjuvant treatment, you have no geographic miss, and the patient is treated locally, and you can go directly to any systemic treatment after surgery. There are data out there. We're currently evaluating this concept in a prospective trial, the NEPOMUC trial. We're performing, of course, together with our neurosurgeons, and the trial is recruiting at the moment. And of course, there are several options available: gamma knife, stereotactic treatment, cyber knife, depending on which capacities you have available at the center. One thing I also think is nice if you want to combine it with post-op systemic treatment is intraoperative radiotherapy. And I know there is an ongoing controversy, but there are trials, prospective trials, randomized trials, international trials ongoing for intraoperative radiotherapy in gliomas. And we're currently in the process within international consortium of setting up a brain metastasis trial to bring this intraoperative concept in for brain mets. And again, I think this is especially important for those patients who need surgery, and then they may need immunotherapy or even chemotherapy after treatment, because then the patient is treated and we may avoid any of those toxicities we've been talking about and we're concerned about. And then, of course, we have the possibility to treat the post-operative surgical cavity, and there are a lot of data out there. I know that Giuseppe Minniti is in the virtual auditorium, who's done a lot of work on that, and I think there are clear arguments to do that. We have infiltration zones, we have remnant cells, and we may avoid whole brain radiotherapy. And again, even if you do radiosurgery or hypofractionated treatment, you do have a benefit of higher single doses compared, for example, to whole brain radiotherapy. And again, if we look at melanoma patients, these hypofractionated local concepts have a benefit for those radiation-resistant histologies. We have published a large group of patients with brain metastases, almost 600 cavities in an international consortium that we published last year in JAMA. Patients were treated quite consistently with 30 gray and 6 gray single fractions, so 5 fractions, and the data consistently showed very good local control, very low toxicity, so a very safe, very safe concept, and especially showed us again that treatment volume, in that case it was cavity volume, was one of the main prognostic factors for outcome. And we're currently validating that concept in a group that was where Matthias Guckenberger is highly involved in the AG Stereotaxie led by the German DEGRO, but it's basically all German radiation oncology or German-speaking radiation oncology centers to really generate a much larger database and to also answer in detail questions. How does this treatment regimen is influenced by additional systemic treatments, by additional immunotherapy, targeted therapy, because this is something that we haven't answered in this multi-institutional analysis. And then, of course, we have radiosurgery, and this is a main topic of this symposium. And you have learned over the last 2 days that radiosurgery is highly effective, and we have local control rates of 70 to 100%, and also long-term enduring local control. And I think this is the most difficult part if you want to break the recommendation of radiosurgery for 1 to 3 or even more brain metastases. We have to offer something that is not only response, that is not only quick response, it's not only we avoid toxicity, but is something that is long-term local control. And I think that is the difficulty for most of the systemic drugs to really break the data that are out there. In the end, I already mentioned the data we always have to discuss with our patients. If we do all these local treatments, do we also need whole brain? Is whole brain gone? Is whole brain maybe coming back? Is whole brain coming back with a simultaneous integrated boost? And just to quickly remember for all of us in the discussion, the data published a couple of years ago, but still I think they're important if we counsel our patients. Local treatment plus minus whole brain radiotherapy. What did the data show? Just a brief reminder. It showed us local regional control, of course, is higher if we do whole brain radiotherapy. This is pretty clear, but it also showed us that any salvage treatments, for example, with radiosurgery, are equally effective in terms of overall survival. So no overall survival benefit. And I think this is one of the main arguments why we generally try to omit whole brain radiotherapy, because we have also seen that, of course, whole brain radiotherapy is associated with neurocognitive side effects. So now if we summarize all of that data, and keep in mind we're talking about melanoma patients, we have learned or recapitulated that with whole brain we have an improvement in local regional control. This is pretty clear. We have the issue of neurocognitive side effects, and then we have the issue that those fractionated regimens are good in terms of minimizing toxicity, but if we have a radiation-resistant histology, they are not really the best treatment you would want to choose. On the other hand, looking at radiosurgery, better local control, very low side effects, and a really good benefit, especially in those radiation-resistant histologies where melanoma really comes in. Of course, we have this problem with local regional control, but maybe if we think about combined treatments, especially in those melanoma patients, you can tackle the visible lesion. We have the benefit of high local doses regarding the histology, and maybe the concomitant immunotherapy can tackle the issue of local regional control or tackling the issue of microscopic spread that we can see on imaging. And then, of course, we can combine fractionated, hyperfractionated, and radiosurgery depending on the case and the individual patient we see. So now, why are we so worried to combine radiosurgery with immunotherapy? And Hussein already pointed it out, and this is a study that was published in 2019 showing us, on one hand, we have very low median survival if patients have brain metastasis, and historically, of course, this is true, although this really has revolutionized overall entities since we have immunotherapy. And then we have seen that with these targeted immunotherapies, we do have enhanced, especially extracranial local control and also survival. And we may have to look at brain metastasis in a different way. And on the other hand, we have learned that those immune-related adverse events may be different extracranially, but also intracranially. And that's coming to the point that immunotherapy seems, or that's the discussion, it may increase the symptoms patients have with radiation reactions. I don't really want to call all of them radiation necrosis, but at least a radiogenic reaction. And the risk of radiation necrosis seems to be increased. And of course, again, then these patients need to be treated with steroids, and that's of course counterproductive if you want to do immunotherapy. And this is really what we're fearing. We have these large edemas, we have these contrast enhancements, and then what do we do with these patients? Do they need another surgery? Do they need steroids? Do they need bevacizumab? Yeah, these are discussions that we have. But really, I think personally, if we think back on the last 100 patients with brain mets and immunotherapy, there are a couple of them. But most of them don't have this large reactions that we usually talk about. If we look now into the literature, look at response rate, look at toxicity, and look at the data that may support that hypothesis. I picked one trial that nicely shows us that stereotactic radiotherapy for brain mets concomitant with immunotherapy does have a benefit in terms of overall survival compared to just doing immunotherapy alone. And this is not the only trial out there. The data is out there for several indications that it really seems that the combination therapy has a benefit for the patients in terms of controlling their disease. On the other side, if you look at the statistical analysis here in table 5 on the right, of course, again, there's this toxicity issue, the radiation necrosis issue, where it shows us that, of course, this group, the concurrent group, seemed to have a higher, or did have a higher rate in the concurrent treatment arm. So that's the fear we're really talking about. On the other hand, there is data out there showing us, again, we have an increase in this case. It's not overall survival, it's local control. So again, a clear benefit to combine, and in that case, no increase of radiation necrosis. So I think personally the data is inconsistent, and most of the data does not take into account the volume and the dose issue that we already mentioned previously. If we look at our own data, we evaluated just recently on patients with brain metastasis in melanoma. We learned basically that the molecular subtype, of course, has a main predictive function. And then, of course, these patients have really tailored treatments, and especially BRAF really has an impact. And if you think about the targeted or tailored medication in those patients, I think we really have to look closely, even if we have effective systemic treatment, that we shouldn't omit the local radiosurgical treatment in terms of local control. This is some data looking at CyberNave data, combining ipilimumab and stereotactic radiosurgery, and showing us two things. Of course, yes, ipi is better than no ipi. That's one question, but the second question is more on the right, is really looking at, is it better to do radiosurgery pre, post, or concomitant? And I think what it clearly shows is that the concomitant, or let's call it the combined data, are better, but it doesn't clearly answer the question whether pre or post in the end is better. And I think this is one of the questions that we really have to look into, which is the most benefit for the patients, but it really consistently shows that the combination does have an impact. Again, here, pointing out combined immunotherapy, in this case, a double treatment, nivolumab and ipilimumab, in melanoma patients, again, with brain mets, plus local therapy. And again, it shows us, in my view, clearly that the combination treatment with local treatment does have a benefit in terms of survival. And if you look at surgery at any time or looking at surgery upfront or later, I think the question is not that clear again, but it really has a tendency that upfront treatment does have a benefit. And personally, that's my experience. If you have a visible and especially a large brain met, do upfront radiosurgery and then immunotherapy. And in my view, the patient has the best benefit from that sequence and combination. If we focus on BRAF inhibitors, this is a nice analysis or systematic review, actually, looking at different studies in combination with stereotactic radiosurgery. And here, looking at overall survival from diagnosis of these melanoma patients, I think it clearly shows the numbers move to the left, showing favoring radiosurgery and BRAF treatment. And if you look at the second slide and you focus on radiosurgery survival, brain met survival, and the different data they put inside, and also the first question looking at BRAF concurrent or after versus doing BRAF before radiosurgery, I think it really shows a clear benefit of combination treatment, and especially in this case, it shows a benefit of concomitant treatment concomitant treatment and radiosurgery before BRAF treatment. So I think, in my view, it supports this hypothesis that local treatment really has a benefit. And if we bring that together, I think timing of radiotherapy is not that crucial. Upfront is generally better, and I think that meta-analysis shows this, but I think the main factor is the size of the lesion, and it's also the prognostic score the patient has. I think those factors are the main factors, but in the end, the timing of radiotherapy is probably not going to be the most crucial question in terms of outcome. So now let's summarize all of that arguments pro radiosurgery, especially prior to immunotherapy. I think we clearly have high and enduring local control, and I think it will be difficult for any systemic treatment to be better than that. We do have very low toxicity of radiosurgery. We have to look at volumes, met volumes, that's here my fourth point. We have to look at that because I think this is the main risk factor. And consistently, the combination data lead to better outcome in terms of local control and probably in the end also in terms of overall survival. Personally, I think in terms of enduring response, the data yet is not convincing to really replace radiosurgery in all of the patients. So personally, I think a combination, and in my view, it's an upfront radiosurgery prior to systemic treatments, will be the most beneficial treatment for the patients. But of course, yes, we need those randomized trials we have to do in our interdisciplinary teams. So thank you very much, and I'm happy to discuss in the virtual auditorium.
So we don't have so many comments in the chat yet. And I'm a bit concerned that you both agree too much. So I anyway still disagree with you. I mean, both of you repeatedly say combination is better, but we need trials. But if you are so convinced, then it will first be a good explanation why both of you don't do the trials. And how will especially Steffi ever convince a patient not to undergo upfront radiosurgery, right? I think to both of you, I mean, the retrospective series where patients drop out that get demented because they don't come back to their doctor, it cannot replace a randomized trial. And I don't really agree with this overall method.
I mean, you're perfectly right, yeah. But I think in the end, we do have very convincing data, and it's I think it's difficult in a situation like that to do a trial that really challenges an excellent and with low toxicity, a treatment that is excellent and associated with low toxicity. And on the other hand, those brain met patients, if we cone down all of our brain met patients, we cone them down melanoma, then we cone them down to the number of lesions, then we cone them down to extracranial disease, and then maybe some other issues. And then we have, I don't know, just a couple of patients per center fitting into a very tailored and targeted trial. So probably in the end, maybe Hussein and I and Michael and all some others, we have to maybe be locked into a room for a day and think about a very intelligent trial design, how we can answer those questions without having 2 patients per center per year that fit into this very tailored trial. But I don't know, Hussein, you can amend to my thoughts.
No, great points, and I don't know that we're willingly not doing the trials, Michael. I think it's exactly your point that it takes a multi-center study, and I will just give credit to Paul Sperduto at in the US. He's been trying to do a randomized trial where he's doing SRS pre or post Ipi/Nivo, and then it has a 2x2 factorial design. The other randomization is fractionated versus single agent in melanoma with Ipi/Nivo. So I think that's a great study to answer those questions, but it hasn't been approved to run, and it was supposed to be a multi-center, across the cooperative groups. I think those are the kind of studies that we need to prospectively do. It's very hard to account for all of the factors that Stephanie just went through with just retrospective evidence. There's so many variables that are not taken into account. And I think the one thing that we agreed on, and I was coming here to convince you of, is the whole concept of like, we shrink down the disease for you and you radiate it, so it'll be better for you and better for us. But I do have a question to all of you in regards to the radiation oncologists in the room. There is a very significant and appropriate reluctance to say, I'm going to put a halo on a patient to do a gamma knife and actually leave untreated lesions. Like, there's this concept that you have to treat all of the lesions that are in the brain at the same time. So we debate this. If I treat with immunotherapy and I have 3 lesions that are responding and maybe 1 that's progressing, can I ever convince a radiation oncologist to put a halo on a patient and treat only 1, not all 4?
Yes, you can. We've done that. We've done that, and yes, you can do that, and that sort of fits also into the question that Giuseppe asked in the chat. He said, what do we do if patients is progressing extracranially and intracranially and is stable extracranially? I think that is a similar question. We treat the progressive lesion in the brain, and at least we in most cases continue the Ipi/Nivo treatment, yeah. And I think it's the same issue. You have, I don't know, 3 brain mets, 5 or 3, 2 are smaller, 1 is progressing. Why not treat that one and see what happens to the others? Yeah, we've done that.
Yeah, and that would be really, that approach would be something that I think if it permeates across multiple centers to do that, then I think we'll be in a place where we can answer those questions in a better way. And I will just address Giuseppe's question about the Ipi/Nivo for LMD. We have some data with single agent PD-1 from MGH that shows reasonable disease control, like I think 10-12%, but The Ipi-Nivo trial was ran at Mass General as well, and I don't actually know the results of that. I can tell you in my practice, I do get some responses to Ipi-Nivo, but what we're doing at MD Anderson, I think I talked a lot about it last time I was in Zurich, is the intrathecal nivolumab. So we're doing one, kind of intrathecal administration, and we're almost up to a little less than 40 patients, and it's been really safe, and it has some interesting disease control that hopefully will be out in the literature soon. And Bella Glitza is leading that trial and has shared some of the data at ASCO as well. So we're getting there, but LMD is the toughest of all situations we deal with.
Hussein, also a question and a comment. I think you don't need to convince us that we believe that cancers are heterogeneous disease, and we do see heterogeneous clones in a single patient, and that there might be a need for local ablation of progressive and resistant clones and otherwise, which are still responding very well. We don't need to apply radiation. The study you showed us is kind of an intermediate trial where you kind of get around the kind of too late and too early. You do a rescanning after 4 to 8 weeks. But could you elaborate a bit more in detail how you select patients for continuing systemic therapy alone, and which patient you choose for applying, let's call it early SRS? Is it the kind of poorly responding? Is it progressing? Is it stable disease patients? So how do you draw that? Where do you draw the line?
Yeah, so a great question. I mean, to be clear, we've put on that specific trial, we've only done 3 patients so far, but it's moving forward. And one of them actually was responding in the brain and didn't need any SRS. All of the lesions were responding. The other 2, unfortunately, progressed and moved on immediately. So, we haven't faced the situation yet, but we're doing it clinically. And I think the most important aspect of this is that that trial is being ran in the brain metastasis clinic. So the patient is seen at all of those time points by the 3 specialties at the same time to make that decision. So we take into account the status of the extracranial disease, the toxicity of the patient, and we do this with Ipi-Nivo all the time. And whether, there is some responding, but some that are progressing to treat. So it's, that's the thing. I think the modeling of our behavior into clinical trials is going to be really hard. I think we probably need like some AI designed clinical trial to represent this, but it is really hard to model all of the variables that we take into account.
Also looking on the time, and I think we're now at a perfect stage to switch to the last talk, but let me thank Hussein and Stephanie for an excellent debate and discussion. Thanks for joining. Hopefully seeing you soon physically in Zurich, or at least at any other meeting. Thanks for joining, and enjoy the rest of the meeting. Now we come to AI trial design, and AI means what we have kind of gone through in the last weeks and months and years. Every talk kind of ends with the conclusion we need clinical trials, and the effort sometimes starts as soon as the last word is being spoken and the speaker leaves the stage. We've put a lot of energy, in particular Michael, to develop such a trial where we have been involving all these disciplines. And we're looking forward to your talk, Michael. What are the difficulties and what trial designs could address the challenges we have discussed today?
So Matthias, can you give me a sign that it works?
Perfect.
Good, yeah. So the biggest challenge may be that you wanted to start your concluding remarks in 8 minutes, right? So that's the first challenge. But I'm going to maybe condense it a bit, and I'm not going to discuss too much the radiosurgery question that we have really been ventilating quite a bit. So I think an important question that has come up is really, do we need dedicated trials for brain metastasis patients, or is brain metastasis just like lung and bone metastasis? And we also don't have dedicated trials there. And I think there are still split opinions about that. So this is a somewhat arbitrary definition of the various phases of clinical trials. And if we look at the phase 0 trial, the biological proof of concept, this is what Emilie has stressed in her talk before. I think that is really an important piece where brain metastasis trial can be super informative. You need only 10 to 20 patients to demonstrate that any systemically administered agent reaches the brain if you just administer that agent prior to surgery. And there are some of these trials ongoing, but they are notoriously difficult. Phase 1 in brain metastasis is probably not a big topic. We have a lot of phase 2 data. We have seen a lot in the last 48 hours. They all had in common, essentially all, that they were uncontrolled, and many of these trials have insufficient follow-up. So here we clearly have to do better. And in most instances, as I will also show you, these phase 2 trials are in fact not true phase 2 trials, but subgroup analysis of other trials with patients with brain metastasis. Phase 3 trials, proof of efficacy of an intervention that has never been done, I think, for a drug that has been a domain of radiation oncology, and the radiation oncologists have really demonstrated that phase 3 trials can be done in brain metastasis patients, but that is some decades ago. So I would like to briefly cover a few topics: eligibility criteria, endpoints, response assessment, and safety and quality of life. So if we talk about eligibility criteria, and we've had that in the discussion on in the melanoma part, which patients do we put on a clinical trial? These patients are heterogeneous at various levels, and if it comes now to clinical trial enrollment, it's certainly the number, the size of lesions, whether they are cystic, necrotic, hemorrhagic, where they are located. So patients are very, very heterogeneous, and if you set your inclusion criteria too narrow, you will never finish the trial. If you set them too broad, you run into very heterogeneous patient populations. If you really go into the definitions by the Rano group, which is sort of the Vatican of all definitions, you also find it not so absolutely clear how you have to measure brain metastasis and what actually measurable brain metastasis are. This is probably even more complicated for leptomeningeal metastasis, but at least in leptomeningeal metastasis, the EANO-ESMO effort has tried to come up with definitions. And if you look at the 3 scans on the right, where one patient has almost no abnormality but cells in the CSF, and then you have this foliar enhancement on the right, and below you have a lot of solid disease that many of you would probably consider brain metastasis rather than leptomeningeal metastasis, it is clear that it is not healthy to put these patients all in the same trial. Now, this is just a list of criteria that may confound the clinical trials for brain metastasis to illustrate once more how complicated it is. And I think we are not at a stage anymore where any of us would do brain metastasis patient trials pooling melanoma, kidney, and esophagus. I think these times are clearly over, but it makes it all more challenging. And some of the big challenges are, of course, for enriched patient populations. Do we need brain tissue? Can we rely on extracranial tissue for patient enrollment? Matthias raised this very appropriate term of active brain mets. I think this term should be eliminated, and I'm going to show you a famous example on that later on. And there are some other limitations that I've summarized on this slide. This, for example, is an example where you think, wow, at the first place, and then if you go into the detail of this study, you get somewhat lost, and I'm hoping that not too many authors of this trial are on the call, but this is just a subgroup analysis of this trial of alectinib versus crizotinib. And if you see on the right, then you see that in this trial, patients needed to have completed, whatever that means, effective local treatment. They had to be clinically stable if they could go onto the trial. And then on the left, you see that there are response rates in some of these patients, and that's again stratified by prior RT or no prior RT. But of course, if I was a radiation oncologist, I would not be very happy if I give irradiation and then 2 weeks later, somebody is put on crizotinib, and the response is attributed to crizotinib. So I think we clearly have to do better, and subgroup analysis like that one cannot replace a randomized clinical trial. That's another famous example, because this drug was almost brought to approval, at least it was tried. This is irinotecan. This is breast cancer. And here again, you have to read the definition. So patients could go onto the trial if they had stable, Matthias would say non-active brain metastasis. And then it was seen that for these patients, those on the experimental arm did better. But of course, there was no formal assessment of the brain mets, not at study entry, and they were pretreated. So it's very difficult to derive meaningful conclusions from such subgroup analysis. And this is also what EMA felt, and therefore this drug was not approved specifically for brain metastasis. Let's quickly look at the endpoints. We have a lot of endpoints available. Some of them have been tried in the brain metastasis field. And I think to be really practice changing in brain metastasis, we would probably go for overall survival as an endpoint if we want to test a systemic treatment. But if we look at a focal treatment like SRS, this would not be fair. We need to define compartmental progression-free survival. We can only assess the compartment that was under treatment. That may sound trivial, but it is not always done like that. And then, of course, we also have the alternative of other endpoints, quality of life, patient-reported outcomes, specifically when it comes to omission of treatments like whole brain radiation. How this may work, I would like to show with this one clinical trial of intrathecal chemotherapy. This is cytarabine for leptomeningeal disease from breast cancer. A study that has a lot of weaknesses, but it's still the only completed one asking such a question. And the trial was positive, but whether such a trial is positive really depends on the endpoint. And this is something that I would like to illustrate on the next slide, where you see on the left, control versus intrathecal treatment. Systemic treatment was at the discretion of the investigators, and the leptomeningeal disease-related PFS is improved. This was significant, but we all know that this is very, very difficult to define. Interestingly, there was also a signal for global PFS, which is difficult to explain if you give a local treatment, but there are some ideas about circulating tumor cells, and there was also a trend for overall survival. Expanding on what has been discussed before, we are now trying to set up a combination trial of intrathecal anti-PD-1 and anti-CTLA-4 across Switzerland, and we will contact many of you in the upcoming weeks to see whether you are interested in supporting this trial. This is a controversy that I think was discussed before by Matthias, if I'm not on the wrong track, but I had difficulties dialing in at the beginning. And still, I don't know whether the melanoma people are still on board. If you look at the conclusion is relatively far-fetched or aggressive, because this is a trial that really omitted SRS from first-line treatment, something we considered standard of care, and the conclusion really is that this should be considered first-line treatment. And I think here you're really taking too many steps at a time. And this is the response from the radiation oncology community that probably has been shown. And it is somehow a weakness of our community that at that time, there was no readiness to simply do an upfront comparison of both as monotherapy and a combination, as we see that in other disease entities. For a clinical trial, we need response assessment. I'm not going to go into the detail. I'm just telling you here that there is not very much agreement, and there is almost no validated data set out there how to really measure response if you rely on imaging. And if we look at progression-free survival, I think there's no way around the imaging that's easier if we look at overall survival. And whether we do that unidimensional, bidimensional, or even volumetric is very debated, because that is all costing a lot of time and effort from those who have to do the assessments. And specifically with regard to the IO that we have been discussing, I do not think that the IRANO criteria have made a major advance here, because simply to avoid the risk of misinterpreting the scans, some specific rules were introduced, like not considering progression too early. But we have to be clear that all these recommendations are based essentially on expert opinion and very little data. We have placed one of these recommendations, how to assess a CNS disease, to a test. That was a large effort, where the RANO criteria for LM were subjected to a test with 10 neuro-oncologists, 9 neuroradiologists, and the result was clearly that this published agreement paper doesn't work. And in all honesty, the brain mets and glioma recommendations have never been subjected to such a test. And to cut a long story short, you need agreements in the range of 0.8 to have good agreement. And you see that for none of these markers or disease features that were subjected to assessment was there any useful agreement. So we clearly also have to improve on that. Finally, safety and quality of life have been stressed. They are important, but they are also very challenging in this disease situation. There is clearly a risk of underreporting of complaints if you ask the physicians. That is shown in a nice study on the right. And then we have patients who may dissimulate adverse events because they want to stay on treatment, or who suffer from neurocognitive impairment. So whether we are really sure about what we are doing to our patients in the long run is very difficult. And that's why I really find these retrospective studies very, very difficult to analyze if you just look at survival of those that can come back to hospital. So to cut this short, we have talked a lot about the multidisciplinary approach. We have not been very good at setting up randomized trials in this disease arena, although all of the colleagues have stressed that this is really important. Matthias, I have still used the term of active metastasis, but I think we should maybe replace it by progressive, as Emilie suggested, or at least untreated, because otherwise I think the interpretation is completely impossible and such trials are useless. We need to have the right endpoint for the right intervention. And while we are improving these treatments, we also have to work on the criteria that we use to assess response, because EMA and FDA will ask for that, and they will also ask for validated tools to assess quality of life and neurocognitive function. With that, I would like to close, and it's not too late, I guess.
Thanks, Michael, for this excellent overview. I don't see any questions in the chat yet.
It's 5 to 7, Matthias.
I know. So, Michael, I don't think you would be super angry if we would kind of wrap up the session. And what do you think?
No, I agree. It was more to let everybody know that we need to do better. And I think if everybody who said we need trials would live up to that, we would be in a better place in 1 year, when hopefully we have a physical meeting again. And maybe you want to invite everybody, because I think we need another one.
I think this is a very good conclusion. So we, as before the meeting, I touched that there was a discussion whether we need a third brain metastasis symposium. The discussion we had here, I think, was very convincing that there's still a strong clinical and also scientific need to continue our exchange. So I would like to come to an end, would like to thank everyone for staying up for 2 days, up to 7 o'clock in the evening. Thank you for your contribution, and I'm hopeful for seeing you soon physically. At the end, I would like to again take the opportunity to thank people who have been contributing to this success. These have been the speakers, obviously, so thanks for preparing your presentations, for showing up, and for the discussion. I would like to thank Silke, who you can see here. You did an excellent job for the preparation. All worked completely smoothly. It was perfectly organized. So thanks for making our life easy and this meeting successful. Thanks for the industry partners for supporting us, and hopefully we can continue with this support. And thanks again, everyone, for joining. I wish you a good evening and hope to see you soon physically. Bye, everyone.
Bye-bye. Thank you, everyone.
Bye. Thank you.
Thanks, Hussein. Thanks, Giuseppe. Bye. Andrea, schönen Abend. Emilie, have a nice evening.
Bis dann.
Ciao, Nikki. Bye, everyone.